we are starting with the third day of our BOS arthroplasty course, which is in Apollo Hospital, Navi, Mumbai. So in this first there is a breakout session on assessment, decision making. Then will be some lectures which you feel that they have been repeated, but they are for your benefit. So last will be there one more session of breakout session. So we'll be starting with the assessment and decision making. So I will ask all the delegates to sit according to their tables they are designated to them. And okay, so we'll start with the first breakout session, which is assessment and decision making.
So that after
same, sir. Yeah, same. The same, but PH are the youngest I have seen. 35, 47. Same as the PH
So I think what happens typically is that most of the young THRs, young kids, they go to the private sector. Maybe they go to the private sector. I've seen them. But
there's an increase in age.
yeah. So since COVID, again, so we are seeing a long as a lot of people are getting also the profile of the young patient is they have got disease which decreases the life expectancy. So they might be 18, but the life expectancy is 50 years. For that, they actually behave like 40 years. Someone who arrived in the chronic steroids. So these are the patients who are very, very young now. Sickle cell anemia. They are really managed. So they are going to one So the oldest patient of 80, सबका cardiac work cardiologist at your place. Government में cross specialty consultation easy होता है लेकिन किसी का
From Kerala. So I don't know if you have a lot of diabetics or alcohol, what is the proportion? But here the chronic kidney disease is endemic. I think most of the corporate hospitals you go to, ये 4-5 nephrologists तो रहता ही है. मतलब एक orthopedic surgeon रहेगा लेकिन nephro ज़्यादा रहेगा. Secondly, borderline is create and all these things रहेगा. ऐसा है. So if someone is on dialysis और वो joint replacement के लिए आता है, so elective joint replacement. So he is doing a joint replacement while the patient is painful. Before the patient undergoes a transplant, better or after a transplant, better? What did they find?
Painless.
No, मतलब आउटकम ऑफ द पेशेंट. देखो ट्रांसप्लांट करने के पहले कर डालना तो इम्यूनोसप्रेशन कुछ नहीं है. सो ठीक है, ट्रांसप्लांट करने के बाद साला इम्यूनोसप्रेशन आ गया. लेकिन जब तक ट्रांसप्लांट कराता नहीं है तब तक रेगुलरली उसका डायलिसिस करता है. एवरी टाइम द कैथेटर इज बीइंग हैंडल्ड, एवरी टाइम देयर इज अ चांस दैट हेमाटोजेनस स्प्रेड ऑफ सम इन्फेक्शन विल टेक प्लेस. So which of the two? So if a patient comes electively to you saying that okay, I'm having this problem but it's not urgent, when do you suggest I undergo a hip replacement? क्या बोल सकते हैं उसको?
Before the transplant.
Yeah, what they found was after the transplant was better. The outcome of the patient, even if they are on immunosuppressant, the outcome of the transplant patient, the patient was better if he had the knee replacement or the hip replacement after the transplant. So he said, get the transplant done. Doesn't matter because immunosuppression रहेगा मतलब infection होगा ऐसा नहीं. But actually immunosuppression होने के बाद, I mean, we are doing the surgery in a clean OT. We are doing the surgery when there is no urine infection, there is no chest infection, everything is clear. So we are operating in a sterile environment. So if the wound has healed, then there is no worry for us. Overall outlook of the patient becomes better after the patient has had transplant. On dialysis they are depressed, दर्द है, फिर dialysis के लिए जाने का है, ऐसा कुछ multiple factors are there. Right. So methotrix. So a lot of people use biologicals अभी. तो उसको क्या करने का, बंद करने का?
4 weeks.
Which one?
Methotrexate.
So methotrexate ना, by and large people have, sorry?
Methotrexate, no need to stop.
No need to stop. हाँ, so nowadays people are saying methotrexate no need to stop. इतना फर्क नहीं पड़ता है. So अपने टाइम पे, हमारे टाइम पे था methotrexate रहेगा, बंद करो, 3 महीने के बाद आ जाओ, 1 महीने के बाद आओ. But अभी nowadays methotrexate we definitely don't stop. Clopidogrel? 5 days. Clopidogrel is a more potent this thing. But again, confusing part क्या ना, American Heart Association has said clopidogrel can be a good this thing, DVT prophylaxis के लिए. But अगर देने का हैगा
तो Renoxaparin is better क्योंकि उसकी half life shorter है.
हाँ नहीं, but उनका clopidogrel का कहना क्या है? They are saying that clopidogrel and aspirin can be given as DVT prophylaxis, but you start them 7 days prior to the surgery. और हम लोग यहाँ बोलते हैं कि तुम लोग साला सर्जरी बंद करो और आ जाओ. हाँ, तो उनका प्रॉब्लम इज ओनली एपिडुरल एनेस्थेसिया. इफ द एनेस्थेटिस्ट आर रेडी टू गिव अ जीए एंड GA and whatever peripheral nerve block, then you can safely do it.
So clopidogrel is more inconvenient for spinal rather than our surgery.
अपने को फर्क नहीं पड़ेगा इतना, अपने को थोड़ा हेमाटोमा होगा.
टीका में नहीं पड़ेगा, लेकिन हिप करेंगे तो ब्लीडिंग वगैरह ज्यादा नहीं होगा.
देख आज भी तो अभी देखा तो ना, ब्लीडिंग थोड़ा बहुत होगा ही. कैंसरस बोन नहीं कर रहा है और तो हिप्स माइट टेंड टू ब्लीड अ लिटिल बिट, बट इतना प्रॉब्लम नहीं आना चाहिए. ऐसा मैसिव हिमेटोमा अभी तूने मतलब रेसिडेंसी के टाइम ठीक है देखा रहेगा, लेकिन अभी कितनी बार हिमेटोमा इवैक्यूएशन कितनी बार करना पड़ता है? देख ना, लास्ट 1 साल में किया है कभी?
नहीं किया है.
किसी के लिए ना, ट्रॉमा के लिए ना, IT के लिए ना, TC के लिए, किसी के लिए नहीं किया.
फूड का ड्रेन सर क्लोपिडोग्रेल चालू उसमें ड्रेन रखेंगे तो
राइट. सो दुनिया ना 2 चीज से दूर जा रहा है, इज टूर्निकेज एंड ड्रेन्स. तो आज मेहता सर ने टूर्निके यूज किया था, मतलब आज डेमोन्स्ट्रेशन था, क्लीन दिखाने का था, वो सब है. बट जनरली हमारे यहाँ 50-50 करता है. टाइम है आज और कुछ करने का नहीं है, मूड अच्छा है तो विदाउट टूर्निके करो, क्योंकि टूर्निके विदाउट टूर्निके करेगा ना तो फील थोड़ा सा ब्लडी दिखता है, कुछ नहीं तो थोड़ा सा इरिटेशन होते रहता है. यू आर डिपेंड लिटिल ऑन असिस्टेंट टू सक एंड टू मॉप एंड लिटिल बिट ऑन एनेस्थेटिस्ट टू गिव हाइपोटेंशन. बट इतना हाइपोटेंशन इज नॉट रिक्वायर्ड नी के लिए स्पेशली, बिकॉज वंस यू हाइपरफ्लेक्स द नी तेरा हीमोस्टेसिस उधर हो गया, ब्लीडिंग स्टॉप हो जाता है, ऐसा होता है. सो दुनिया धीरे धीरे टूर्निकेज एंड ड्रेन से दूर जा रहा है.
टूर्निकेट्स नहीं यूज करने का फायदा क्या सर? ये तो आपने बोला कि ऐसी कंडीशन में वो नहीं यूज करेंगे.
नहीं, सो फायदा क्या है टूर्निकेट नहीं यूज करने का? इज बिकॉज अभी क्या हो रहा है कि वी आर मूविंग टुवर्ड्स मेकिंग द सर्जरी मोर एंड मोर फिजियोलॉजिकली लेस डिसरप्टिव. ओके, सबसे पहला चीज गया इज दैट वो इंट्रामेडुलरी कैनाल विद नेविगेशन एंड रोबोट. इंट्रामेडुलरी कैनाल का तो ये होता है फीमर का, तो वो हम लोग वायलेट नहीं कर रहे. फिर उसके बाद हम लोग टूर्निके यूज करना बंद कर रहे हैं, तो उसकी वजह से टूर्निके बंद करने से जैसे वो एनॉक्सिया जो होगा टिश्यूज का, लैक्टिक एसिड जमा होगा, वो सब कम होता है. थाई पेन कम हो जाता है. ठीक है, टाइम अभी क्या हाई वॉल्यूम सेंटर्स में टाइम कम हो जाता है. टाइम कम निकलो, टूर्निके बांधो, निकालो. फिर एक खादा पेशेंट को टूर्निके रिलेटेड बर्न्स हो गया या फिर प्रेशर सोर हो गया तो वो हेडेक नहीं होना चाहिए ऐसा. तो इसके लिए आई थिंक साइंटिफिकली इट डजंट मेक एनी डिफरेंस ऑन अ ट्रांसफ्यूजन रेट्स. So what they did was three things.
No, then what? Okay.
Three things was, one was tourniquet, one was no tourniquet at all, and one was tourniquet only while cementing. When you compare these three things, what they found was the risk of transfusion was the highest with tourniquet elevated only for some time. उसका reason क्या है समझा नहीं. They also have not said क्या reason हो सकता है, but blood transfusion parameters, drop in hemoglobin was more when you selectively raise the tourniquet only for a short while.
Okay, so the other go for total
Tourniquet
tourniquet
or
or
no tourniquet.
but don't go for no tourniquet with tourniquet
With
with
cement.
cementing.
So tourniquet with cementing also is slowly going out. क्योंकि अभी क्या समझ में आ रहा है कि जब तो ब्लीडिंग तो एनीवेज होने वाला है, हम लोग सीमेंट करो उसका टूर्निकेट छोड़ो, ब्लीडिंग एनीवेज होने वाला है. सो ब्लड इज गोइंग टू कम इन दैट इंटरफेस. सो ब्लड इज नॉट बैड, बैड इज फैट. अगर तेरा सबक्यूट फैट है कुछ आ गया, फैट विल नॉट डिसॉल्व. सो फैट विल कॉन्स्टेंटली फॉर्म अ फिल्म बिटवीन द सीमेंट एंड द बोन. सो दैट विल नॉट लेट इट इंटीग्रेट. सो थोड़ा ब्लड आ गया तो भी कुछ फर्क नहीं पड़ता है. सर यू आर सेइंग समथिंग?
What to do with the clopidogrel then, sir?
Clopidogrel we stop.
We stop.
Because our anesthetist doesn't give GA. They will prefer to give spinal or epidural.
But sir,
How many
we are
more
operating
Five.
35-year male patient
हाँ.
for the knee, for the unicondylar.
Yeah.
In that case, if we are suppose that anesthetist will say that we will give the GA, so we should keep the clopidogrel.
नहीं, अगर वो क्लोपिडोग्राल लेता रहेगा तो 35-year-old patient generally then he is a patient who is not going to take clopidogrel.
But if there is some condition in which they are ready to give the GA, then we are okay to keep the clopidogrel continuing.
From an orthopedic point of view, if you are able to tackle the bleeding, you can. But अगर तेरे को ऐसा लगता रहेगा कि नहीं, quality of platelets is bad and don't want unnecessary ooze, you are much safer to stop it than continue. कंटिन्यू करें क्या, अगर अपना बड़ा ही मार सकता है कि अरे हम लोग कोई दवाई बंद करने की जरूरत नहीं है. बट अगर कोई कॉम्प्लिकेशन हो गया, यू विल कीप ऑन थिंकिंग दैट व्हाई डिड आई डू दैट.
aspirin anyway, no need to stop.
So aspirin again no need to stop.
तो एस्पिरिन भी डोज रिलेटेड है. अगर 75 चल रही तो कोई इशू नहीं है, अगर 375 चली तो कहते हैं स्टॉप कर दो.
Yeah.
1 day before. Even 75 can be given on the day of surgery.
कोई स्टॉप करने की जरूरत नहीं है. तो जैसे आप टाइमिंग की बात कर रहे थे, अगर हमें टूर्निकेट नहीं यूज किया तो बार बार ब्लीडिंग होगी, तो उसमें नहीं टाइम जाएगा, बार बार हमें वॉश करना पड़ेगा वो.
So इन्होंने वो भी देखा है कि जो हाई वॉल्यूम या नॉट हाई वॉल्यूम बट मॉडरेट वॉल्यूम सर्जन्स है ना, फॉर द सेम पर्सन देयर इज नॉट मच डिफरेंस इन द ऑपरेटिव. ये वो एक्चुअली होता नहीं है इतना ब्लीडिंग. सो हाँ, आई सेट हो जाता है वो ना, आंख को आदत हो जाता है लाल लाल दिखने का. अपने को शुरू में लगता है एकदम क्लीन लग रहा है, बट अदरवाइज ना तो खाली मॉप करेगा तो वो सेट हो जाता है.
विजन हो जाएगा
हाँ.
कि अपने लाल लाल को इग्नोर करना है.
यू सी डॉक्टर नीलेश शाह वीडियोज ऑन द दिस थिंग. उधर तो एक्टिवली से यूज होते रहता है. मतलब मैं बोल रहा नहीं कि उतना होने दो, फिर भी वो फर्क नहीं पड़ता है इससे.
बल्कि कुछ लोग तो कहते हैं जब यूज हो रहा है तो सर कितना मत किया करो, बार बार आप ब्लड ही सारा सक कर दो, रहने दिया करो. उसमें मतलब कुछ लॉजिक है नहीं, क्योंकि वो ब्लड है, अल्टीमेटली मॉप करेगा तो सकी करेगा वो, तो इंट्रावेस्कुलर में से एरिया से निकल गया. ऐसा है.
So what is your take on tranexamic acid?
We use it all the time. Tranexamic acid has proven its place. So at induction you give tranexamic acid and 6 hours later you can do. There are numerous publications to support us, and there are numerous publications to say that tranexamic acid in a patient who has got a stroke or a procoagulable state also it doesn't make a difference. So you can safely give. In fact, tranexamic acid has now come even in trauma situations.
Yeah, we also give it.
Yeah, trauma, massive exsanguinating trauma रहेगा तो फटाफट tranexamic acid we can start. What about this thing? Biologicals. Biologicals will have to be stopped. Biologicals will interfere with wound healing, so they will have to be stopped. Then वो adalimumab and then there are 1 or 2 monoclonal antibodies that also will have to be stopped. और lupus patient रहेगा उनमें भी they use this thing, immunomodulator है ना एक mycophenolate. So mycophenolate का भी डोज कम कर रहे हैं, मोफेटिल. So उसका डोज भी थोड़ा सा कम करना पड़ता है क्योंकि that will interfere with wound healing. उसमें से mycophenolate मोफेटिल जो है वो थोड़ा कम करता है, इतना नहीं होता है. But best is to stop it if the nephrologist allows. Steroid, in fact, you might need to step up. Steroid, I don't think it should be a problem. Steroids, you can give steroids. In fact, patient is dependent on steroids, so you'll have to get this thing done, cortisol levels done. So if you do the cortisol levels and you find the cortisol levels are okay, then you don't. But वो क्या बोलते हैं, Addisonian crisis prevent करने के लिए actually increase the corticosteroids में, है ना?
एकदम से टेपर.
हाँ?
तो टेपर करो एकदम से बंद.
नहीं, तो corticosteroids बढ़ाना पड़ता है. सो पेरियड पीरियड में यू हैव टू इंक्रीज द कॉर्टिकोस्टेरॉइड्स so that patient does not get that addition in crisis. We are discussing about how optimization. Sorry?
What were blood sugar levels when you were giving drop for corticosteroids?
Intropney, this is given in the morning of the surgery. Morning, yeah. So they have to be monitored. Then you have to control it with insulin and things like that. Yeah. But the demand, but if the patient lands up either in a thyroid crisis or an additional crisis, that will be a bigger headache for us to tackle.
It's about 50 at the time you had a mean age, the thinking of the TKR, maybe 50 to 80, maybe 30 may not be that much, but yeah.
Yeah, but what I'm trying to say is that if they're used to steroids and there is a suppression of the steroid axis, then there's a big problem. So generally the patients will ask. Rheumatoid patients, you always ask for cervical spine X-ray. You always ask for suppression of cortisol axis. अपना देश में तो काफी सारा patient Ayurvedic they have tried at some point in time. So you don't know whether they have taken steroids or not. ऐसा है.
Anything a crisis probably is not only a crisis for us, even the physician is under
Yeah.
stress. Better that you pump steroids
Yeah.
pre-operative and tide over it and then
So we will manage the sugar with the insulin if patient is in steroid. But the major issue is does steroid decrease the immunity at the local level? Does it increase the chances of infection?
See, Abhi, I think yes. So all these things, rheumatoids, they anyways have got little vasculitis, a little immune system का गया रहता है. Plus they are on steroids. Plus if they are chronic kidney disease, then there is a problem. So these patients anyways are a slightly higher risk. Okay. But what I'm trying to say is that these factors may not be modifiable, but our surgery is modifiable. So see, surgeries we are doing in good operating theatres. We are doing it as first thing in the morning. We are ensuring that it's a consultant lane. तो ही बंद करता है, सब कुछ close करता है. So जब वो open होने से close होने तक अपने हाथ में सब कुछ है. If you are doing that well and the rest of things are controlled, then more by and large things should be okay. In spite of our precautions, the patient might get infected. That is a different issue. But I think that should not be steroids we should not be afraid of nowadays. So immunosuppression also you should not be afraid of if it's because of steroids. If it's because of that mycophenolate, MOD and then wound healing is a problem. Steroid में again wound healing problem रहेगा, लेकिन आजकल वो प्रिवेना, वैक ड्रेसिंग्स, वो सब काफ़ी सारा चीज़ आया है which will aid in wound healing. वैसे है. बिगर प्रॉब्लम इसको क्या करेगा?
सर एक्चुअली दिस इज द साइकिल जैसा है इसका कि पेशेंट को हम बोलते हैं कि बीएमआई कम करो, लेकिन कैसे करेगा? उसका नी काम नहीं करता.
राइट. सो दैट्स व्हाट मोस्ट ऑफ द पीपल से. अच्छा, नी काम करने के बाद हाउ मेनी पीपल लूज वेट?
वो पता नहीं.
पहला क्वेश्चन होता है
सो
दवाई दे दो हमको कम करने.
दो अच्छा स्टडीज था. एक था डू पीपल एक्चुअली लूज वेट आफ्टर इकडे.
If you are, if the patient is fit, all parameters are fit. Again, अभी TKR है तो bilateral करना है, unilateral करना है. So above 70, don't do bilateral. That is something very safe. So don't try to do it on the same day, bilateral. So do it, stage it. One is same stay or later. So you can do it one on one day, second on second day or third day. That you can do if the patient remains fit on one day. But don't try to do it on the same day.
Why this slide is put, basically don't sell your services. Okay? So there are many young patients coming up, just a unicompartmental medial joint line reduced. People are selling it, to be very frank. Always and always a patient will be happy when they have genuine symptoms. Such patients will be happy doing good physio rehab, some lifestyle modification, weight reduction and few medicines. For them TKR is not, the patient won't be happy. But if suppose a patient has a genuine deformity, cannot walk without a pain, then these patients operated for a TKR will be happy. They will bless you like anything. Don't sell your surgery. The patient needs a surgery, yes or not.
And scientifically also, age-related morbidities जो है, osteoporosis है, severe है, so 80 osteoporotic, that is a red flag sign. So you should not do it. Don't touch them unless, so you can give prayer prehab, prior bone density, ये सब करके then only. So prepare your patients well, even if it is aged, and don't skip steps, protocols.
So now protocol regarding renal compromise. So what is your view?
Renal में see one there is osteoporosis, two osteoporosis. So renal osteodystrophies जो grading है वो two higher chances of infection. So you have to keep that in consideration whenever you are doing a patient of chronic renal disease. So you have to again counsel necessity of the surgery, how important it is for that patient. Somebody who is on 3 dialysis or a week और उसको TKR है तो why should you do it? Wait and watch. Unless he is a very fit person, ठीक है, chronic renal disease है, not dialyzing, infected diffusion नहीं है, ये सब, then you can go ahead and do it.
When do you plan to stop methotrexate, biologicals in RI?
There are papers that you should stop. I think 2 weeks, ना कितना?
Methotrexate can, if it is continued, okay. Etanercept 2 weeks. Adalimumab, golimumab 4 weeks.
Methotrexate can be continued
Okay,
till the day of the
continue. And prednisone less than 10 milligram can be continued. More than 10 milligram, you bring down to less than 10 milligram in tapering dose, and then
5 days. You can shift them to aspirin.
various newer blood thinners which are missed usually. You don't even know these are blood thinners. So, taking account which blood thinners are going on and how many days to stop. Because if the patient is on rivaroxaban or something, and it cannot be directly stopped. There was a rivaroxaban started for a particular reason, maybe DVT or others. So you have to convert into low molecular weight heparin and then plan the surgery.
For this proper history is a must. Most of the time what happens is, when I have seen, patient is admitted, then the anesthetist goes to the file. अरे ये तो
And there are बहुत नए blood thinner है. I just found one blood thinner a week back. Tikara से मतलब 90. A lot of them. I didn't even know that is a blood thinner. So
actually when a patient tells that I am on medicines other than painkillers and everything, you should chart them down. What medicine he is on.
you should not only see the prescription, try to see the strips, the chemical name. To see Ecosprin 75.
In fact, you should, if you are taking clopidogrel, you can stop clopidogrel and put him on Ecosprin.
The anesthetists are very precise, 3 to 5 days depending upon the anesthetist. They tell to stop clopidogrel. Now the moment that is stopped, shift him on Ecosprin, which is more safer. 24 hours prior, just keep a dose. Post spinal 24 hours, you can restart.
Low molecular weight.
No molecular.
Low molecular can continue only on the day of surgery and 6 hours after.
When we have to restart that? Means after
Low molecular weight immediately after 6 hours after surgery.
methotrexate post of day 1. Methotrexate post of day
You
1.
can continue.
When you start the oral drugs.
BMI? Your sensor? If suppose it's above 40.
नहीं है तो मैं सोचा सबका नहीं आएगा.
नहीं टेंशन मत, सबका वहाँ तक आएगा. और
बड़े बड़े लोग हैं.
आवाज ही
मेरा आवाज से कुछ नहीं
यहाँ इसके लिए आया कि मुझे सीखना था, बाकी सब जगह पे सीखने नहीं मिलते.
यही बोल बोल के हमारा
लाइव जा रहे गौतम सर अभी देखते रहेंगे.
The body mass index, something more than 40, I would say strict no. More than 40 body mass index is a strict no. When it is more than 35, you have to evaluate the risk versus benefit, how beneficial the surgery would be for the patient, or go for weight reduction. Mild weight reduction is not the option. You have to go for extreme weight reduction and only go for surgery, because
the chances of infection increases, because when the patient is obese, there is chronic inflammatory process going on. A pro-inflammatory marker known as adipokine is high in the body, which has got a propensity for infection. And along with obesity, these guys will always have some metabolic syndrome. And along with metabolic syndrome comes diabetes, insulin resistance, cardiovascular disease, and all this will increase the chances of PJI, periprosthetic joint infection. Along with that, obesity increases the duration of the surgery. It is said for every 1 kg per meter square, the surgery time might increase by 2 to 3 minutes. So that duration of surgery is also going to increase. You have to adjust the prophylactic antibiotic according to the weight of the patient. The usual 1.5 gram cefuroxime or other antibiotic won't work. You have to increase the doses of prophylactic antibiotic also.
Wound healing, even in normally wound healing, even if there is no PGI, but wound healing is delayed, so you have to account for that. So watertight closure, all the layers should be closed. Adipose tissue should be additional suture line for the adipose tissue, and then whether you should use, that might be there in the other slides. Staples in those of obese patient you may not use monocryl. So, or many times, I personally do it many times in very obese patients with a vacuum dressing, incisional vacuum, better healing.
Any experience on bariatric surgery prior to this?
So above 40, you should always tell them to go bariatric.
Above 40, you should just avoid.
Tell them to come back with 15 kgs reduced.
Send it to someone.
Parkinson's, you do?
That's what I said earlier. Parkinsonism, if it is a florid Parkinsonism, no. I don't think they are osteoporotic. Gait control is very poor. क्या करेंगे
सर का ये बोलो ये सर का
how rigid the knee is. Okay, so how rigid the knee is. Okay, so usme we'll have a, when you all come for an advanced arthroplasty course, then we will talk about this. Okay. You want to add something? एक मिनट. Hello.
Keep the stems ready. Be ready for
हाँ बोल ना.
closure. Do it in layers. Single layer.
नाही काय नाही करायचं. मी तू घरी पोहोचा मी तुला फोन करतो. गरज नाही.
Skin closure.
मी तुला सांगतो संध्याकाळी फोन करतो.
We are using subcuticular stitches. You use a stapler.
आता मी जरा मीटिंग मध्ये आहे. त्यांना सांग मला 1-2 तासांनी फोन कर. नाही गरज नाही. संध्याकाळी.
Whatever fluid is coming, it will come out in the first few weeks. Closure wise, you have to be that way clear. Yes, you don't give a too tight closure on the subcutaneous tissue. Too much whitening should not be. Use ample amount of whitening. But skin, you should not use Echelon. Don't use steroids. So normally I do not use steroids. That is the problem.
Okay. Now they have mentioned a point about sleep apnea. You know what is sleep apnea? What is sleep apnea?
Sleep apnea means tongue gets down and there's obstruction.
So, and it's very common, more common than we think. So when the patient lies supine and if he's relaxed, the tongue falls behind, tongue presses on the trachea or the respiratory tract, and the patient does not get enough air during sleep. This happens at around 2 o'clock in the morning, 3 o'clock in the morning. Okay, and the patient gets less oxygen to the tissues. Because of this, the cardiac system is thrown into overdrive, saturation drops, and to maintain saturation, the patient's BP increases. During sleep, BP increases, tachypnea occurs, hyperventilation occurs, and sometimes the patient breaks his sleep and he gets up all sweating, hyperapnea and hyperventilation. Okay, and it is serious. It is a problem which is serious. These patients can actually die during surgery, and we sometimes see heart attack ne mela tasan असतं ते. It can happen because of sleep apnea. One example is Bappi Lahiri. Bappi Lahiri died of sleep apnea. Okay, so what is it related to the TKR surgery? तो problem ये होता है कि in a TKR, obese patients generally avoid doing bilateral surgery. तो इतना lengthy surgery नहीं करने का. But even for a single TKR, from the anesthesia time to till the dressing time, 2 घंटा तो लगता है. हमारा काम, experienced person like him, he will be doing the TKR in 45 minutes to 1 hour. Okay, but वो आगे का टाइम पास पीछे का टाइम पास तो होता ही है ना. 2 घंटा पेशेंट सुपाइन नहीं सोता है. पेशेंट्स विद स्लीप एपनिया एंड TKR तो सुपाइन पोजीशन में करने का है. Okay, so how do you tackle this issue? So first of all, you have to give a head up. Give a head up, foot end को low कर दो. So the diaphragm falls down. There is less pressure on the chest, and that's why they can breathe more easily. Tell the anesthetist कि इसको sleep apnea है, be ready to intubate. So उसका सब तैयारी होना चाहिए. Give a more thicker pillow below the head. Okay, थोड़ा सा. So all these things are required sometimes.
पोस्ट ऑपरेटिव भी नॉर्मली वार्ड में हेड लो देते हैं स्पाइनल अवॉइड हेड लो हाँ these patients. Some people are on CPAP or BiPAP. If they are doing that home, they will not tell you. So they use CPAP at home. You have to inquire all these patients, obese patients specifically, whether you are using any devices for sleeping at night. If they are using that device, they should carry it with them to the hospital so that you don't have unnecessary surprises at night. So you have everything in the hospital, you have CPAP, everything, but you will have to run unnecessarily. And once the patient has an episode, it doesn't only require a CPAP or a BiPAP, it will require a ventilator. Instead of that, just avoid.
Okay, so another thing, I will go to the previous slide. Interop tips and tricks made regarding the tourniquet. We all use tourniquet during TKR surgery, but for obese patients, the thigh is fat, thigh girth is more, and thigh is conical. So sometimes the tourniquet does not sit well. You have to use a wider cuff. You have to apply the tourniquet as proximal as possible, and most important is before draping, inflate the tourniquet and see, check it. Check करो वो ठीक से काम कर रहा है. Because if it's not working properly, it's better not to use the tourniquet at all. We can do TKR without tourniquet also. It takes 10 minutes extra, coagulate all the bleeders, but it is possible to do. In certain situations, it is indicated. Okay, but obese patients always check the tourniquet if you are doing a tourniquet TKR, right? इन्फ्लेट करके देखो, अप्लाई करो उसको पेशेंट को. नहीं वो इन्फ्लेट हुआ है कि नहीं नहीं तो वो लीक रहता करके वो ये हो जाता है. It just rotates.
So once it is conical shape. So pre-operative Parkinson, whether you will do a TKR or not. So one thing that we have been taught in arthroplasty, and if we have Parkinson's, avoid arthroplasty, right? So, but rather if the patient is having preoperative Parkinson and severe osteoarthritis, whether you will do it or not.
Parkinson's, sometimes patient is having symptoms in the hands, and if the knees are arthritic, then we should go for the.
So Parkinson's also has changed over the years. The medicines have changed. Many things have changed. You have to consult with your neurophysician properly. What stage of Parkinson's? If the patient is not having too much severity, too much of being controlled well on medications, nowadays I still undergo. Patient having too much amount of rigidity, not able to exercise, having gait problems, then definitely should avoid. Other than that, I do not avoid.
No need to avoid, but always involve a physician or a neurologist in the perioperative care. And the drugs, whatever the drugs they are taking, drugs for rigidity or drugs for mobility. You should be aware of those drugs and they should continue them after the. Okay. So clinically, TKR patient में what do you examine before surgery? Patient comes for TKR. सर मेरा घुटना दुखता है, 70 साल का उम्र है, दूसरे डॉक्टर ने TKR बोला है, TKR करना है. That is given. But what do you see?
Joint line tenderness. Actual, we see any laxity, the virus is correctable or not.
Yes. Why is that relevant? Virus है, but वो correctable है. Why is that important?
It is important because we have not released too much of the soft tissue during surgery.
Yeah.
Don't cut too much of the bone.
Yes.
Medial release not too much.
So soft tissue releases on the medial side will not be required or less required. What else? FFD. Okay. Why does the patient have a preoperative FFD?
There is a posterior osteophytes, so patient cannot extend the limb properly.
Okay. Only osteophytes or what is the other reason? Which soft tissue? Hamstring nahi. Capsule. So posterior osteophytes in the femur or sometimes tibia and tight posterior capsule. These are the reasons for FFD. And clinically अपने को मालूम होता है. So how do you deal with FFD? Now that you have brought up the topic, it's an important, and every third patient that we see, we have FFD. How will you tackle the whole thing? FFD, chalo, we're talking. No. Don't jump the gun. FFD is 30 degree 1 day before surgery. And you plan कि इसको हम लोग ऑस्टोटोमी करेगा, +3 मिलीमीटर कट लेगा, ये करेगा, वो करेगा. No. On table, first examine under anesthesia. जो 30 डिग्री प्रीऑपरेटिव था वो डिसअपियर होके 10 डिग्री पे आता रहता कभी, because it was because of the pain and spasm. So now you have to deal with only that 10 degree, जो रेसिडुअल 10 डिग्री है उसको ही डील करना है. Okay, so that's important. But now suppose residual uncorrectable 20 degrees FFD है. I'm giving you a figure. Intraoperatively क्या changes करने पड़ेंगे आपको? To release नहीं, you have to remove the osteophyte. Remove the osteophyte. How will you remove? How will you release the posterior capsule? But how will you release the posterior capsule? What will you do exactly? Curved or straight? Very good. Okay. Yeah. So Dr. Ranawat recommends that you should use a cautery to cut the capsule. Some other surgeons recommend that you use a sharp knife, 15 number knife to cut the capsule. I am a very darpoke surgeon. I want to do it very slowly. So your technique is the best. Curved osteotome. Someone on the femoral side will lift the femur. Someone on the tibial side will distract the tibia. The joint flexion may open ho gaya. Use a good light from behind to reflect it into the posterior recess of the bone. Then take a curved osteotome, take a hammer, and under the posterior surface of the femur, tak करके धीरे-धीरे you release the capsule. This is the safest way. And as it described, you do the same?
I normally do same. Just use the osteotome. I used to just tap it with my hand.
So
simpler way. If there is some bony this thing, then yes, and never use a heavy hammer. Always. There are two hammers on the table for TKR. One is a heavy hammer, one is a soft hammer. Use a soft mallet and just go.
You don't want to over-release the capsule also, because if you lose the capsular support from behind, post-operatively the patient can go into hyperextension. It's a very bad thing. Happened with me once.
And never use the osteotome on the posterior aspect of the tibia.
Because the vessels are near the tibia. Vessels are near the tibia.
we do this in the femur, then everything is fallen. If you try to do this on the posterior aspect of the tibia, same thing, you will end up damaging the non-neurovascular bundle.
So important है.
So clinical examination में, coming to the clinical examination, most important thing about clinical examination is the patient will come to you saying I have a knee pain, he'll be ready for surgery, मेरे को कल operation करने का है. Don't get too excited. Examine the patient again, rule out hip and spine pathologies. Any of your colleagues must have seen, somebody must have referred to you from somewhere, sir, ye karo. Patient might have a spine pathology. Don't believe on anyone, not even me. मैंने तुमके पास तुम्हारे पास भेजा. Don't believe on me. You examine the spine. If the patient has a spine issue, he will not be happy post TKR. If the patient is having hip problem, he will not be happy with TKR. You have to rule those out first. So clinical examination that way is again important.
Okay. Right. So from TKR now we go to THR. Nisarga, you read that X-ray. Read the left hip.
So this is a PVH X-ray.
Okay.
And
Male or female?
male patient.
क्या कैसे मालूम? Okay, it doesn't matter. हाँ.
It is center. Both the obturator foramen is visual clearly.
Okay.
And it is
Let's go to the hip. Let's go to the hip.
Hip is enclosed hip, and it is
What is your diagnosis?
encloses only enclosed hip. Bilateral enclosure. And so in right side also there is arthritis, or secondary arthritis due to ankylosing.
So you are telling that this is ankylosing spondylitis, right? Okay.
Without wheelchair, or don't walk without a walker or a stick. Give them that support. That way. Yes, clinical examination.
So what test is that?
Rotation test.
Sorry?
Like you're checking the rotations. Hip rotation.
Okay.
Sectoral side.
Okay. That is MRI. AVN is an MRI diagnosis. I would never say MRI. AVN is a clinical diagnosis. Okay. So what is happening on the left side now?
Ankylosed.
Ankylosed. Why you say it is ankylosed?
There is no joint spacing fully.
Okay. Trabecular crossing the joint. So what type of ankylosis is that? Will we having pain more on the right hip or the left hip?
More pain in the right.
Yes. Why?
Movement is slight movement is there.
See, there is a difference.
No joint.
This is
Joint is there.
that could be. I am asking you the difference between fibrous ankylosis and bony ankylosis.
Bony is never. It is more for a function rather than
Yeah.
pain. And fibrous will always have this type of joint will be more painful. Obviously, they will not have any movement that in that side also. That
Hello?
will be more painful. I say.
Hello. Yes. Can you hello?
So
Huh. पासवर्ड ते व्ही कॅपिटल आहे पी आहे
specifically in hip,
small
we should be seeing
आणि
cervical, lumbar.
25 12
we should be
40
able to, examine other joints.
व्ही कॅपिटल पी स्मॉल 25 12 40 मग ते त्याच्यावरती क्लिक करावं लागेल की आय डोंट हॅव आउटलुक सो कॉल मी ऑन मोबाईल मग मी इथनं तिचं ते ऑपरेट करतो ठीक आहे
Mainly what we see is ankylosing only, very commonly.
25
The neck is not moving,
1
the
2
spine is not moving, hip is bony fused.
1240
In these cases, we have to see what is the sacral tilt and all, to decide if we need THR or we need spine before THR. We need spinal
correction before THR, because we feel as arthroplasty surgeon इसका तो hip खराब है, ज़्यादा hip लगना चाहिए, but if he is completely tilted or is sacral, sir will be speaking on the sacral, what is the sacral alignment, slope, tilt and all that.
So how will you clinically distinguish between a bony ankylosis and fibrous ankylosis? This is a classical postgraduate question.
Job of movements are present in fibrous.
And very painful. And this will be painless. Pain-free rather, not painless.
Some movement will be there in fibrous.
Yeah, but it will be extremely painful, isn't it? That's the whole classic. So what is this picture with the silver nails over here? So what is the shape of the digit in psoriasis? Mostly in the finger. It is not in the toes, right?
Because in psoriatic, DIP joint is involved. Distal phalangeal joint is involved. In RA, DIP is not involved.
So it is a sausage-shaped finger in the psoriatic arthritis. So, next one.
So what we were saying is that why it is important is because these problems, spinal will be difficult in them, epidural spinal will be difficult, mostly mouth opening is not there and neck extension is not there.
So last 15 minutes for a first breakout session to get over.
Achha, we are back. And spinal deformity. Yeah. So yes.
So who do you think this radiograph is adequate?
No, sir.
Why?
Spine.
Spine?
Using the rotation, I'm able to see it.
Yeah. So it is more into internal rotation. Next. Okay. So basically,
No one told femur कि we should be taking minimum 1/3 proximal femur always.
Spine can be declined.
See, now the concept of taking a sitting and standing lateral spine has come, mainly because now we are doing too many spinal fusion surgeries, lumbar spine fusion surgery. So because of that, our sacral tilt is changing, and because of that, our cup position becomes too much vertical in that fused spine. That's why we have to take lateral spine, and mainly all robots have also made it hard. But for EHR, minimum X-ray you should be looking till the isthmus. That is minimum X-ray that you should be taking. The first X-ray PVH, you should never operate, never. That is a complication which has happened different. But you should never operate on X-ray on this, because what we advise is PVH. We don't take a femur. We should always be seeing till the isthmus.
they take always pelvis. I don't know. I tried to explain to them so many times. We write pelvis with both hips. That by default should come down to isthmus. But you end up getting the upper iliac crest and L3, L4 vertebra rather than anything up to lesser trochanter. I don't know how you guys are doing the X-ray, but I always struggle with PVH in my place.
Second, the bowing that we can get. Yes. So coming to true size X-rays. Now templating sir, we have today.
What is wrong with this X-ray? If suppose you was to template on the right side, will you accept that? Suppose if your professor is very arduous, so will you be accepting this? Will you accept this X-ray for templating for the hip on the right side?
We don't have any proper, like we used to keep a coin which we can take.
No, there is that a marker there? Well, I think that is a marker. So I think we are running late. So just to recollect one more time, if you just put the plate under the pelvis, the magnification becomes 10. If you put it in a cassette underneath, the magnification becomes 20. External rotation. So what causes external rotation? External rotation, the hip will go into external rotation, the femur will appear shortened and the cortices will appear thickened if you are looking for the doors. Okay? What else? Version will be difficult to get onto. Lateral is okay, lateral is fine. Suppose now I'll ask you a question. If suppose you are having a flexion deformity of the pelvis, how you are going to take a marker X-ray? Marker X-ray means this marker X-ray. This is a flexion deformity of the hip. So how are you going to take that? You place patient in a sitting position or you drop the table just like this. Okay? Osteoarthritis generally have external rotation. These are classical MS standard question. Nowadays, I have not done digital templating also for many years now. So if it is an external rotation deformity, how you are going to take it? Bilateral hip external rotation deformity. Prone position. So that you want to make the neck parallel to the cassette. You understand? Suppose there is a bilateral external rotation deformity like this. It is generally Faber, isn't it? So how do you want to bring the neck parallel to the cassette? That is the principle. So you ask the patient to lie down prone. You make a P-X-ray type of thing. And then rotate the knees just like you do for this pediatric FFD deformity, internally and externally, till it becomes parallel to the floor. You understand? That is the way we do the templating. But this is a question because nowadays seldom anybody goes in my, you need to go proper X-ray.
We'll be talking more on templating also, exactly how we'll be templating.
Yeah. Okay, is this lateral view acceptable? Is this acceptable, lateral view?
This is what we get always.
No, why it is not a true lateral? Both condyles are not superimposed and...
So how this X-ray has been taken is this way and not a true lateral. That's why they cannot take a true lateral in frog leg lateral because you are external rotating tibia and the femur is not. So that's why. So you should always take knee lateral by taking the patient in lateral position and then taking X-ray also. Yes. Always, pre or post or both.
It is very common in the lateral hip. They do some funny abduction, external rotation and just shoot it. They should go to shoot through true lateral. Keep, suppose right limb is safe, bring the left foot to 90-90 and shoot the gun through the groin and a plate over here.
Lateral for hip, na?
Shoot through true lateral.
Shoot through lateral का कैसे लेते हैं?
Shoot through true lateral. You must go and do that.
हाँ, वो Google पे भी देख लेना. If I am taking right lateral,
Yeah.
तो left is this way. अपना बीम यहाँ पे, कैसेट यहाँ पे रखा और ऐसे ही लिया एक्सरे. तो इसको shoot through hip lateral बोलते हैं. तो ये frog leg lateral एक रहता है और एक shoot through lateral. नॉर्मली जहाँ पे हमें अनस्टेबलनेस लगता है, DHS पहले के ज़माने में हम लोग शूट थ्रू लैटरल करते थे क्योंकि ऐसे करके वो हमें लगता था सो शूट थ्रू लैटरल एंड फ्रॉग लेग लैटरल. नाउ टॉकिंग अबाउट स्पेसिफिक नी का, नॉर्मली वी शुड बी टेकिंग स्कैनोग्राम्स. ठीक है, ऑब्वियसली ये जो है हिस्ट्री पे मिलेगा और कभी कभी पेशेंट्स डोंट टेल. Now, if you don't have a scanogram facility, ideally you should be taking femur AP, tibia AP and knee AP, individual ऐसे, and make a working scanogram rather than if you don't get a scanogram, because you should be knowing any extra articular deformities are there or not. That way. So,
जान लेगा वापस में.
They do differ.
So, have you anybody done subastis? देखा है? Most of seen.
It's good to do.
Good to have knowledge. As I said, what he said is very nice. A thin patient where you are able to comfortable, not to cut. But again, the retraction has to be there because we want to expose the joint. We want to retract the patella. I mean, it has to be there. Go to next.
Innervation is too much sometimes, and that is why patient is not able to do it. तो फायदा क्या होगा?
So now there is a joint is stiff, like a flexion deformity of 30 to 40 degrees. So, so tell me now, what is advantages? Knee is stiff. Any specific thing? In short, what we are discussing is the knee is completely stiff now. So now any special, because normal knee 5 to 10 degrees of flexion difference. The knee is stiff for 30 to 40 degrees. Any special things you will look for, special tricks you are going to do intraoperatively, and how is going to help? चल बोलो, make skin subcut हो गया, अभी क्या करोगे? Absolutely one. Could be that could be last. Anything else?
In ankylosed knee, which cut you will take?
Yes, that was my wanted that. बोलो ना, which cut will take? Normal cut कैसे लेते हैं?
कैसे? Femur का alignment कैसे पता चलता है तुम्हें? Femur is always intramedullary. You cannot go. But tibia is extramedullary. So tibia का 0 level पे पहले cut ले लो. 0 means not at 9 or 10. Take minimalistic, take a cut.
So at least you know, and there you can have a play there. Now, for example, hip में भी आगे समझा ankylosing है. अभी तो can you remove the head? I don't think so. What people say, remove the head only, na. At least until you achieve that thing, and you see the acceptable. So what Saurav said, very nice idea. They like take a cut which is very minimal, and so that you get a play to it. And then again there are two ways of thinking. Doing tibia and femur, it has its pros and cons. So if you are not able to dislocate or you don't want, some people take femur cuts also. It is not that you have to mandatorily take a tibia cut, but we conventionally are very comfortable doing that. That's it. As you said, femur is always intramedullary, tibia is extramedullary.
If the knee is flexed in more than 40 degrees, then you will get that entry point of the femur. Otherwise, you are not going to get the entry point. Extramedullary femur is haywire. Never.
And you should avoid that much as well. So as there is a 20 to 30 degrees of flexion deformity, only where we can go anyway. That's not. And doing that femur will be good advantages because we are not disturbing anything. And then other precautions where you are going to take the soft tissue, which is most important in the stiff. And sometimes going more aggressively can land up in a big trouble, like cutting some collaterals which we don't want. So go slowly on that.
Yes. So the first periprosthetic fractures are extremely common when you try to do a range of motion in these patients.
So you have to be. Maybe I will go either way. If you can first see under anesthesia, if possible, that also is very good. See under anesthesia, range of motion, you are able to do it. Because sometimes the patient due to the pain doesn't do. Some with the pain vision do. So by doing the range of motion, you understand. You can do that much. So, and definitely doing a release. So where to release also, like where are you going to do? So what are you going to go completely more medially, or how? And when you are going to dislocate in stiff knee, I am talking predominantly. Are you going to take one special features, or what you are going to tell? Very good.
You release that to the deep MCL you go. If you can still flex the knee, you start removing the meniscus. Then you start seeing how much movement you are able to do. Sir told us about the quadriceps that you should flex. So eventually you will be able to flex the knee, and then you go towards the posterior on and see if you can, whether with the posterior on some extremities come out, then you see how much of the flexion is there, then you plan your
Very good.
So the specific point on outcome of stiff knee, you have to tell him you are not going to get the full range of motion, because it is not only a joint which is important, it is the length of the muscles that is equally important. So वो patient को उतना range नहीं आने वाला, it is just the pain free, a more range of motion till maximum 90 degree, that patient can have a normal social life.
And even also I like to do, like if there is a deformity more than 30 to 40, don't tell him that your knee will be straight, because there could be some and we can't, and don't try to be God there. Like be as much as possible. And as he said, the range could be 8, 90, 100. So expectations, sometimes getting a patient can get a good range afterwards, but there are so much of other factors also, because he's not sometimes stiff. Also can other joints could be also affected. That also is important there.
Except the superficial MCL, what else do you not release?
You have to release almost everything. You have to release almost everything, and that do with very, very much care, because there is a disuse atrophy of each and every ligament and every muscle there. It's only a paper thin cortex with paper thin ligaments.
What is the difference in OA and RNE? And what precautions you are going to take in OA and RNE?
So RNE will have a symmetrical complete reduction in the distance.
Anything else? Predominantly RA or varus or valgus, predominantly. And why?
So attention all will
So
Close the first breakout
valgus predominantly. It doesn't make.
So
Because
I would
depending
like
on the disease, that condition.
call Dr. Ashish sir to just end this breakout session and give his comment.
Just a question that do you use drain or you don't use drain? So drains again, it is a thing. So again, it is really we are thinking big patient, obese patient. They are not very comfortable.
Everyone has had their share of the pre-op planning regarding choice of patient, making sure that you have investigated the patient and seen him clinically so that we are ready for the surgery, and a little bit of pre-op planning. All these aspects will again be covered in the
मैं नहीं हूँ, मैं बुड्ढा थोड़ी। Hi. Yes, sir. Welcome. सुनील तू भी आ जाना, अमित तू भी आया।
ये सागर
कुणाल तू भी आ जा, खाली केस करेगा।
आना अमित, अमित गरुड़ परमिशन है।
ना आएगा क्या? पास पास आगे पीछे थोड़ा। So I'll request Dr. Kiran to come up to the dais. Ashish, ऊपर. प्रमोद तू भी एडिटर है बाबा. सचिन तू जा. कौन है बुला तू ही दे दे. So I hand it over to Dr. Sachin Kale to introduce you to the book.
Yeah, good afternoon everyone. This is like my fourth book. This is regarding the robotic arthroplasty. Initially we started with having that only one, 2 quiz. Then we decided to have a little bit of practical guidebook. And with Pramod, Ashish, Gaurav, and especially Dar sir, he is my guru only. I am not anywhere near him. His blessings are there always with me. So we will have this book. Let Pramod, you have a few words on this.
So this is the book that we have been working on since last 1 year almost. Dr. Kale, as he's an avid writer, he's been after us, all the authors, to write this book. We have finally got hold of the whole this thing, and it is ready to be published now. Thank you to all the writers, editors, co-editors. I have Dr. Kale, who is the editor. Dr. Dhar sir, he's helping us for everything here. Dr. Gaurav Kanade, Dr. Savan, Dr. Saurabh Kulkarni. Dr. Saurabh Kulkarni has done a huge amount of work. He's helped us a lot around this book. Dr. Ashish Fadnis, Dr. Santosh Shetty, Dr. Sunil Shetty. Where is he? Yeah. So thank you everyone. Thank you for the we can start with the thing. Dr. Sunil, please come.
We would have given you the free copy, but it is not printed yet. It is just.
Yeah. Congratulations, team, and it's really privileged to be part of this. And I'm sure everybody knows Apollo Navi Mumbai. Beyond what we do on fabulous basis, all clinical program, orthopedics is one department which is really helping us to have a stature of a state or national now. All these activities, which is research, academics, publications, will also over a period of time dominate from Apollo Navi Mumbai. We know that as in today, we have 110 students in almost 19 specialty. Be it now barring opthal, dental, and maybe endocrinology, almost all specialty, we have a DNB program here, 110 students, which is largest in Maharashtra when it comes to the private hospital. So all these academic activities will help to build the quality in the hospital. So this is one of our aim, and we'll be happy here on. Dr. Dhar is always requesting, on all member of Orthopedic Society is always requesting us, please count us Apollo Navi Mumbai all the time to do all activities, all support from our side, be it be space, be it be some support when it comes to the all arrangement to be made, we are there. And Dr. Dhar lightly said, but we are upgrading this setup maybe in months' time. It will be completely digital setup, including the lamp and all that thing will go off, screen and all that thing will be digital, nothing needs to be called from outside. The cost per event also will go down up there. So technically, we will be happy to host all the events which Bombay Orthopedic Society wants, and maybe participate in a meaningful way. Thank you, and looking forward to assist. Thank you.
Thank you, Kiran sir. I'd like to tell Ashish, the BOS secretary and the co-convener of this course, to have a few words.
Thank you very much, and thank you very much, Dr. Dhar, for having us here. And thank you very much to Apollo Hospital. You have been very supportive of all our courses. And this year we'll be coming again in a few months' time, and a couple of months' time will be the basic trauma course. So Apollo has been very supportive, especially when it comes to hosting delegates to attend the operating theatres and letting us use these facilities for as long in the day as possible. So we've got a very good program today. There is ample space for you to have small group discussions with very good infrastructure that Dr. Gaurav, Dr. Sachin and everyone has sort of put together. So just make good use of the facilities, the faculty, and just make sure your time here in Apollo is and go back with really good memories for a lifetime. Thank you very much.
So we'll move forward to our next session. So I will call upon Dr. Saurabh Kulkarni, sir.
Good afternoon, all. So, in this first lecture, we will be seeing the key steps in planning total hip replacement. It will be a basic one, and it has been very well said that somebody who fails to plan is actually planning to fail. So, and that is very much true for the total hip replacement more than the knee replacement. So we'll be seeing the key steps in planning of total hip replacement. Suppose a patient has come to your OPD, then this is how you should plan the total hip replacement surgery before entering into the operation theater. Initially, it starts with the vigilant history, then the proper clinical examination, then the radiological evaluation, and then later on, again, a patient counseling after knowing all the complications that those are possible in the surgery. So in the history, basically you have to authenticate the hip pathology is the cause of patient's pain. There can be a radiculopathy, there can be a claudication, there can be a SI joint referred pain, which is mimicking the hip problems, and after the doing total hip replacement surgery, you will be in soup that the patient is having till the pain. So the arthritic pain in the hip joint is usually in the groin and a lateral hip, sometimes in the anterior thigh and referring to the knee also. If there is a pain which is in the gluteal region, you have to be very careful that this can be a referred lumbar spine pain, or this can be from the sacrum or the SI joint as well. Arthritic pain typically is very worse after the activity, and it gets relieved by the rest. Then you have to see age, preoperative diagnosis, the level of activity of patient, what is his profession, and allergy to any metal type or latex material, because this usually affects your implant choice. Then the mental status of the patient, whether ready for the surgery and its postoperative pain, involvement of other joints, conditions that prevent the use of crutches or walkers like some fractures or arthritis in the wrist joint or a shoulder joint, medical problems, patient's expectations, and antiplatelet medication also has to be seen, because all these factors, they affect your result. Then the quantification of symptoms and results is equally important, as we are ever evolving. So we can use a Harris-Hip score, SF36 score, or whatever your hospital is using. You should use that scoring system to authenticate and validate your results. The spinal problems and the previous spinal surgeries also has to be asked in the history, because whether the spinal anesthesia is safe or not can be seen. Hyperlordotic spine conditions, they cause pelvic obliquity. Then the clinical examination, you have to check for the fixed flexion deformity, leg length discrepancy, the gait assessment, including Trendelenburg test, has to be done. Even the vascular status of the limb has to be properly checked. There are a few institutes which have a color Doppler as a primary investigation before the surgery, which is, I think, very much valid. Patient's body mass index also has to be calculated, as obese patients are very high-risk patients for the periprosthetic joint infections as well as the fracture. Adduction contractures should be seen. They cause apparent shortening. Abduction contractures cause apparent lengthening. Fixed flexion deformities of the hip, they forces the lumbar spine into lordosis, and that also results your acetabular cup placement. The fixed lumbar spine deformities like scoliosis, and ankylosing spondylitis, they cause fixed pelvic obliquity, and you have to consider them while putting your acetabular cup into the place. The soft tissue around the hip joint also has to be assessed for any inflammation or scarring or any eczema or an infectious condition which may affect your result. The strength of the abductor musculature also has to be checked by the Trendelenburg test, because there are many literature which says that the preoperative abductor muscular strength on a normal side also is an indicative of the postoperative results. The limb-length discrepancy is usually actual or apparent, is decided by or affected by hyperlordotic spine conditions, pelvic obliquity, hip flexion contractures, and the Trendelenburg gait. Radiological examination is followed. Then the weight-bearing radiographs should be done. Then long leg radiographs are better to be done. And you should, when doing a long leg radiographs, you should be considering a block test, where a block is placed under a side which is on a lower side, and then a square pelvis has to be done. So what is a good quality radiograph for the total hip replacement? The pelvis should be square. There should be a standardized magnification. The femur should be seen minimum 10 to 15 centimeters below the lesser trochanter. An AP view should be taken with 15 to 20 degrees of internal rotation. You can see the effect of rotations on a hip X-ray. The first X-ray is without any internal rotation. Then you are seeing a very smaller neck. So the length and the offset you will be missing. And if you do the internal rotation too much, then the lesser trochanter will be out of the picture. Then you have to check for the canal flare index, the quality of bone and anatomy of bone. That affects your fixation of implant and choice of implant. So what is this canal flare index? It is a ratio of canal width at 2 centimeters proximal to the lesser trochanter to the canal width 10 centimeter distal to the lesser trochanter. So if the canal flare index is less than 3, you are into a stovepipe, Dorsey type, and there you might have to go for the cemented implant. Uncemented also can be done, but you have to be very diligent about it. And normally, if it is above 4.7, it is a champagne fluid, Dor type A. There the rimming of femoral shaft is extremely important. Normally, most of the patients, they are into 3 to 4.7, where the choice of implant is as per the surgeon. Then you also have to look for the femoral bow. A radiological assessment of the hip joint also has to be done. Joint space narrowing, presence of osteophytes, superolateral osteophytes, inferior osteophytes. There are some medial osteophytes also. And also you have to look for the center of hip rotation. and planning of medialization has to be thought of. The limb-led discrepancy is usually checked by the bi-ischial line and its relationship with the lesser trochanter. Also, a more stable parameter is an inter-teardrop line and the distance of lesser trochanter according to this inter-teardrop line. How do we measure the limb length in long leg radiographs? Usually a proper length is given by the iliac crest going through the center of hip rotation towards the tibio-talar joint, center of the tibio-talar joint. Radiological evaluation in DDH, if there is a severe DDH, better to get a CT scan with 1 millimeter of slide thickness. The false profile view is considered to understand the anterior coverage of the acetabulum in DDH cases. Then we have to measure femoral offset as well as acetabular offset. So what is this femoral offset? This is usually horizontal offset. It is the least distance between femoral head center of rotation to the longitudinal axis of femur. Vertical offset is from that center of hip rotation to the lesser trochanter. Reducing this offset leads to lax and weak abductors, which increases the joint reaction force, leading to pain, limping, instability. Also, there is an increased chance of impingement. If there is an increasing offset, then you are decreasing impingement, but there is an increased soft tissue tension leading to wear rate, higher wear rate. Acetabular offset is also important. It is defined as a distance between acetabular center of rotation to the vertical line drawn through the teardrop, and combined offset, which that it decides the hip abductor muscle function. So you have to try to mimic this combined offset after in the surgery. Then the implant selection. Cementless implants are usually used in younger patients with more activity and more physical demands than the older patients with the poor bone quality and less activity profile, low demand patients, which are candidate for cemented implants. Then comes the templating. The goals of templating are to estimate the position and insertion depth of the implant, to select the appropriate size of the implant, to predict whatever are the difficulties intraoperatively, and ultimately to restore the center of rotation. Stepwise approach has to be taken. So the first step is the seeing the magnification. The external markers are usually used for assessing this magnification. Then the teardrop, ilioischial line and superolateral edge of the acetabulum, they are marked. The inferior edge of this template cup is at the teardrop. The superior edge of this template is at the superolateral edge of the acetabulum, and this cup usually touches the ilioischial line. The inclination that you should give is 45 plus minus 5 degrees, but ideally 45. This is how the templating is done. Then the acetabular templating in cemented cup. You also have to understand there should be a 2 to 3 millimeters of equal cement mantle all over. So while templating, consider that. And suppose after doing a proper templating, if there is a superolateral defect that you have to fill with the cement, you have to prior think it and reproduce in the operation theater. In case of protrusio acetabuli, you have to consider the peripheral rim contact, and your template should be lateral to the teardrop and lateral to the Kohler's line, and accordingly do the templating, and you have to reproduce these results. In case of DDH, the templating should be lateral to the teardrop and in contact with the ilioischial line whenever possible. So templating to assess the offset, the trunnion should be at the level of center of rotation, planned center of rotation of the hip, and this template should define the level of femoral osteotomy which you have to reproduce in the operation theater, and size of the stem approximately is given here. So ultimately, why templating? Because it forces the surgeon to do the surgery in the brain first and then in the operation theater. It greatly improves the precision of surgery. It shortens the length of procedure and also reduces the incidence of complications. So after doing all this planning, then again a final counseling of the patient has to be done, seeing he has to be properly told all the complications,
and then the surgery has to be taken. Thank you.
Good afternoon, everyone. I'll be talking on prevention of joint infection. So this is a topic which is going to remain relevant till however experienced the surgeon is. This is going to be followed irrespective of at which stage of career you are. The most important thing what this equation, the Altama equation, says that the infection would be degree of contamination multiplied by virulence of organisms divided by host resistance. A simple maths says us that we have to decrease the numerator and increase the denominator. So we will have to increase the host resistance and decrease the virulence of organism and as well as degree of contamination. A very good paper by Dr. Javed Parvezi, who is a pioneer of infection in the world, has given a 10-step approach how to prevent a surgical site infection. I would say each and every person in whichever stage of career he is, he should read this paper and we will come to know that what we have to do in order to prevent the joint infection. The steps being optimization of risk factors, sterilization of implants and instruments, bioburden reduction, respect for soft tissue, expeditious surgery, minimal blood loss, reducing the operating room traffic, wound management, antiseptic irrigation solution, and preoperative antibiotic prophylaxis. If we see, these 10 steps are going to cover almost all the points which are necessary before, during, and after surgery to prevent the infection. Coming to optimization of risk factors, the risk factors, these are totally in our hand to control and they belong to the patient. So they can be further divided into either they can be modifiable, which we can modify before the surgery, or they can be non-modifiable, which are impossible to modify, and we have to go about the surgery considering these risk factors. There are various risk factors, like the first one being obesity. This is the most asked risk factors, how to manage it, how to go about it. The problem of obesity is when the patient is obese, there are chronic pro-inflammatory markers like adipokine, which has a propensity for causing infection. Hence, the risk of infection in obese people is more than normal. It is said that for every 1 kg per meter square BMI, the time of the surgery increases by 1 minute. And this duration of surgery will further contaminate the surgical field and increase the chances of infection. The patients who are obese have something known as metabolic syndrome, which in turn causes diabetes, cardiovascular disease, and insulin resistance, which again add to the infection possibility. It is said that 5% risk is there in obesity, and the patient is obese as well as diabetic, the risk increases to 10%. The body mass index of more than 35, the risk is almost 6.7 times in knee replacement, and it is 4.2 times in hip replacement. The cutoff for my personal experience and my personal practice is 35. Any patient more than 40, I have never operated a joint replacement, and one shouldn't. Unless and until patient has undergone some bariatric surgery, or you should ask the patient to see a dietitian. Once the body mass index has come down, then only you should go for surgery, otherwise no. Urinary infection. After the age of 70, especially in females, there is something known as asymptomatic bacteriuria. All the literature, papers say that asymptomatic bacteriuria does not cause joint infection, and you can go ahead with the surgery if the patient is not having any urinary symptoms. But if the urinary symptoms are present, you should go for culture, identify the organism, get the sensitivity to the antibiotic, give that antibiotic prophylactic as well as post-operative to prevent the infection. The other factors like diabetes, the HbA1c has to be less than 7.5. The fasting blood sugar should be between 90 and 130. The postprandial blood sugar should be less than 180. The literature says that the diabetic patient preferably should be operated early in the morning because the sugar control is well under control in the morning and it goes on deteriorating as the day goes. A patient with rheumatoid arthritis, you should ideally consult a rheumatologist, but when the patient is on prednisone, you have to taper it off to less than 10 milligram per kg. If the patient is on methotrexate, you need not stop. But if the patient is on biologics, which are now given to almost all patients nowadays by rheumatologists, if he or she is on etanercept, you should stop 15 days prior surgery. If the patient is on adalimumab or golimumab, you should stop at least 4 weeks prior surgery. Smoking increases the risk of tissue hypoxia. Ideally, it is said that stopping of smoking 6 to 8 weeks prior surgery prevents the tissue hypoxia. Malnutrition, protein, rather than the total protein count, albumin less than 3.5 is a more possibility of joint infection. So you should increase the level of albumin in the body. A body mass index of less than 17 is also indicator for infection, so you should try to increase it as well. A hemoglobin of less than 11 in Indian scenario, I would say, has got more chances of joint infection. Other factors like HIV infection, the patient has to start highly active antiretroviral therapy, but obvious with the consultation of infectious disease specialist, and a CD4 count of more than 200 should be there. Any infection, oral, skin, nails, should be treated before the surgery. Skin condition, many times patients with eczema and psoriasis have scaling of skin over the knee or hip. That should be addressed with the help of dermatologist, then only the surgery should be taken. Any previous local surgery, there should be a team approach. You should consult a plastic surgeon if you are not aware what kind of skin incision should be taken. But if there are previous skin surgeries, there are previous knee replacements, HTO, or any other surgery, the most safest incision is the medial most incision on the knee. Any other condition like cirrhosis, kidney diseases, cancer, immunosuppressants, one should consult the respective doctors and then only go for surgery. A patient of high risk is the one who has got maximum non-modifiable risk factors. So these patients should be counseled well for the advantage versus risk ratio, and then the decision should be made whether we should go ahead for surgery or we should look for an alternative approach. A middle risk patient is a patient who has got the modifiable risk factors. We should modify the risk factors, bring down the risk factors to bare minimum, then go for surgery. A low risk patient is a patient who is well under control. We can directly go for surgery. Reducing the bioburden is the main step in doing the surgery. Ideally, a patient should be advised to get a chlorhexidine gluconate bath a day prior and on the day of surgery. We should go for proper skin preparation, right from shaving to washing with a beta scrub. Nasal decolonization. Usually, it is a source of Staphylococcus aureus. So, if the patient is having severe infection or nasal complaints, one should go for nasal decolonization as well. Preoperative antibiotic prophylaxis. The drug of choice is second generation cephalosporin throughout the world. In India, we use cefuroxime with 1.5 grams before the surgery, but it should be judged according to the patient weight, which is around 20 milligram per kg. And it should be given at least 15 to 30 minutes prior to the surgery so that at the time of surgery, the serum levels are highest. If the patient is of moderate risk and at the risk of MRSA, it should be added with vancomycin or linezolid. Vancomycin is more preferred to linezolid because it is, literature says, a bactericidal antibiotic is more preferred than bacteriostatic. Vancomycin being bactericidal is more preferred over linezolid in prophylactic antibiotic, as a prophylactic antibiotic. Other factors like sterilization of implant and instruments have to be taken care of. Respecting the soft tissue. You should try to aim and achieve and replicate your procedure in each and every time. You shouldn't keep changing your steps. You shouldn't keep changing your approach. The more you replicate your procedure, less the time of the surgery, less the blood loss, and less the chances of joint infection. Try to use instruments wherever possible. Don't try to retract the things with your hands or fingers. It is said that less electrocautery means less chances of infection. Try to use absorbable sutures everywhere. In fact, even the skin closer can be done with monocryl 3.0, which has got more favored in terms of PGI than the skin staplers. Coming to surgery time, any increase in the surgery time more than 20 minutes, the chances rise by 25%. Whereas the surgery time more than 60 minutes, the risk of the infection would be 37%. Preoperative tranexamic acid, which is ideally 15 milligram per kg body weight, should be given 60 minutes prior to the surgery. It can be put locally in the surgical field as well. And post-operatively, it can be given at 3 and 6 hours. Reducing the operating traffic to the bare minimum is of importance because you should allow only the people who are important to the patient and to you to be inside the operation theater. Less the number of people, less the chances of infection. Usually we do not give a wash after surgery of povidone iodine during joint replacement, but the literature says that 0.5% betadine or povidone iodine helps to reduce the chances of infection. Watertight closer. This is extremely important step, especially in obese patient, that you should do a watertight closer along with the adipose layer as well. And try to use absorbable sutures, something like subcuticular sutures of monocryl, which will help you to further decrease the chances of joint infection. Bilateral versus unilateral. Bilateral, along with cardiovascular complication, has got more risk of joint infection as well. So, when the patient is fit, is on low risk, you can ideally go for bilateral without any risk of PGI. But the criteria should be, as it is for cardiovascular as well as joint infection, age less than 70 years, less than one comorbid condition, either hypertension, diabetes, or pulmonary disease. If the patient is diabetic, HbA1c less than 7.5, BMI less than 35, and hemoglobin of more than 12 gram per cent. Thank you.
Excellent presentation. Any questions from the audience?
So whenever patient comes to you with HbA1c of more than 8 or 9, so you wait until his HbA1c drops or till his sugars gets controlled if you want to do it in urgent condition? You ask the patient to wait for 2-3 months.
Ideally, I don't wait for 3 months, I would say. I see to that 3 consecutive sugar days, the fasting as well as PP are under control. That should suffice. If HbA1c is extreme high, more than 9 or 10, then one should stop. But if it is at the borderline, say 8 or 9, then one can go depending on the fasting and PP if they are under control for 3 consecutive days.
What is your take on the bilateral TKR on one day or in stage? Some of the surgeons do it on day 1, then do it second day on the day 2 or day 3.
It should be done within 2 days. If you are doing it bilateral simultaneous, then on same day. If the patient is cardiovascularly fit and anesthesia and physician have got no problem for surgery, not only from joint infection point of view, but from cardiovascular risk as well as point of view. And if it is a stage procedure, because it should be done within 48 hours. After 72 hours, I would say the inflammatory markers come into the picture and the risk increases more as compared to simultaneous bilateral knee replacement. So either single day or maximum I would say 24 hours gap. That's all.
So what extra care do you take while operating the obese patient? In terms of the suturing also, or do you prefer applying VAC on the sutures?
When the BMI is, I would say, more than 35, the patient, I would say more than BMI, if you are doing the closer, you will come to know that the adipose layer and the fat layer is very thick. At that time, you have to get the adipose layer suturing as well. And this adipose layer has got the propensity to undergo fat necrosis. And this fat necrosis gives a serous discharge after surgery. So if you think that this adipose layer is of extreme thickness and this might undergo fat necrosis, then you might, it is good to give a prophylactic VAC on incision, VAC dressing for first 5 days. Then it will prevent the fat necrosis and the serous discharge. And go for watertight closure along with skin of subcuticular sutures, mainly monocrel, I would say, and to avoid staplers.
When will you worry about if your wound start discharging post-surgery? If discharge comes after day 1 or 3, will you worry, or after 2 weeks?
I would worry after day 3. First 2 days, usually if you are doing if you are doing a closer, and nowadays we are extreme rampant in mobilizing the patient. So many times because of that rampant mobilization, in first 48 hours, there is soakage of the dressing, the blood will come out. So need not worry for first 48 to 72 hours, but, and especially if the patient is on blood thinner. But after 72 hours, I would say there shouldn't be any soakage. If there is
give wound wash or?
No, I would say we wait. We just give a prophylactic antibiotic and take into consideration on the risk factors, but shouldn't open so soon, not on the 3rd day. We should wait for 2 days. We should stop the mobilization of the patient, maybe stop the physiotherapy, and try to give it limited mobilization, wait for 2 to 3 days more, and then explore the idea of wound wash versus wait and watch.
So thank you, sir. So I will call upon Dr. Deepak Gautam. He is a consultant joint replacement center in Medicover Hospital, Khargar. So he will be talking approaches to the total hip replacement.
Last postprandial drop. It's a pen drive. Do you want to start in this one? Oh, sorry. Okay. So yes, we are in a basic arthroplasty course. Before I start my lecture, I just want to know from the delegates, what was the approach that you were trained in for total hip arthroplasty or that you have seen during your residency? Anyone? Posterior approach? Anyone in lateral approach? Lateral? Oh, raise your hand, no problem. Lateral approach, okay. Anterior approach? No. Anyone, where your consultants used to or your teachers used to do posterior approach for total hip arthroplasty and lateral approach for bipolar hemiarthroplasty. Anyone? Don't hesitate. Yeah. Did you ever ask them what was the reason for changing the approach in 2 surgeries, even though the ultimate goal of the surgery is the same, you are replacing the joint? Yeah? No, no. So we'll try to dig out everything regarding the approach. So that's why I wanted to talk an overview of the approaches in this. See, I trained from an institute where, I only saw total hip arthroplasty. I never saw muscle pedicle graft. I never saw osteotomy. But during the examination, during postgraduate examination, we are not allowed to utter the word total hip arthroplasty in the beginning. Am I right? That happens to all. Even though the patient was admitted for total arthroplasty, you are given a hip case for your examination, and you are not allowed to tell that in the first what is the treatment. You start from all those lengthy theoretical things, muscle pedicle graft, osteotomy, and last word would be total hip arthroplasty before you finish your examinations. That's the basic difference in teaching and practical difficulties. So approach is to be learned so that you can use it practically in your practice as well. I'll go through these slides. No video today. I'll just discuss about the approaches. One. Second, how to judiciously use the approach, and why do you need to know all the other approaches as well. Yes, you are comfortable with the approaches that you are trained with. You are comfortable with the approaches that you are doing the regular surgeries. I was trained in posterior approach. I did fellowship in lateral approach, and today I am doing all the cases by anterior approach. Something crazy like that. But there are certain reasons for everything. Total hip arthroplasty is a proven very highly successful surgery. There is no doubt in that. See the satisfaction rate in total hip arthroplasty and total knee arthroplasty. You don't have to be bothered with the patients. Unless and until you have done anything gross, total hip arthroplasty is very fantastic surgery. That's why in Lancet it was the operation of the century. But still, we're trying to evolve and trying to find new things in it, by it in design, to improve the functional outcome. Yesterday only, this is my third day in a lecture, row by row. I was in Hyderabad the day before yesterday. Yesterday I was in Delhi and today I'm in Mumbai. All hip days, all hip sessions. So why are you talking if the success rate is so already high? So we want to be best, can be better. Okay? So then again came these two things. In knee, you go, everywhere people are talking about alignment. We are forgetting the basic. In hip, you are coming about designs and approaches. Newer designs, newer implant and approach. Same hip, you want to enter into the joint and replace it. Go for posterior, either lateral, anterior, in between anterolateral. Several names given for the same approaches with few modifications in each. You have the mini versions of each by shortening the length of the incision or the releases or the cut of the muscles. Whatever, but the basic principle remains the same. You will learn all these names during a postgraduate examination if it's required for the examination. After that, we'll finish it. But grossly, what it means, you know the approaches, how to enter the joint from anterior or lateral or posterior. That's why, see only for this posterior approach. The single Gibson original distinction was vertical. It was modified, little lateral, again all posterior, and given the different name. KL and modified Gibson's approach. But the basic principle remains the same. That doesn't change your basic principle. Come to this particular article. That's important again during the postgraduate study. Same anterolateral approach was done in 4 different ways. And at least one of these 4 papers, the term anterolateral was used to describe approaches that are completely different in terms and anatomy and function. But we are using it randomly. Say, same lateral approach, you see direct lateral, hard hinge, modified lateral, some other way, little difference in the muscle touching or the incisions, but the approach remains the same. If you go back, the original posterolateral approach, the posterior approach was described by Moore. Lateral approach by Kevin Hardinge. Watson-Jones approach was never described for total hip arthroplasty. It was for fixation of fractured neck of femur. It was lateral, modified by Rottinger that you are using today, or that the anterolateral surgery is using. That's the Rottinger approach, the modification. And comes the anterior approach, initially described by Hutter and lately in 1980s rejuvenated by light NKG. Posterior approach, the incision is positioned laterally with the patient in lateral position. The gluteus maximus muscle is split and the short external rotators along with the posterior capsule is detached to access the hip joint in toto. Posterior approach, patient in lateral position, you are entering the hip joint through posterior capsule. Lateral approach, the incision is centered over the greater trochanter and the gluteus medius is split or partially detached along with the vastus lateralis to give a direct access to the hip joint. Yes, it preserves the posterior structures. Those surgeons that were doing lateral approach for fracture neck of femur during hemiarthroplasty and total hip arthroplasty posterior approach, that was the reason behind that, because you are preserving the posterior structures to prevent the posterior dislocation. And comes the anterolateral approach, somewhere in between. The incision is made, the anterolateral approach can be done in supine as well as lateral position. The incision is made over the anterior part of the greater trochanter and the interval between TFL and gluteus medius, with possible partial detachment of the anterior gluteus medius and the minimus. Not possible. You almost always end in injuring little part of gluteus medius or the minimus, giving the access to the joint, because you want to see the clear access of the joint or the 3D view of the acetabular cavity. It also preserves the posterior structure. And comes the direct anterior approach, which is entirely different from others. The incision is made over the anterolateral aspect of the thigh, though it is said direct anterior. Enter the joint directly from the anterior capsule, but the incision is a little anterolateral. It's the muscle sparing intramuscular internervous pure plane between the TFL and sartorius medially, between the TFL and sartorius and rectus medially, TFL being laterally, and exposing the hip toward the anterior capsulotomy. Now, so grossly, we have posterior based approach, lateral based approach, and the anterior based approach. So if you are doing anterolateral approach in supine position, it's an anterior based approach. Posterior approach is split the gluteus medius. It's a fantastic approach, extensile approach, most of it forward. But it has its own sense. It's an excellent approach, but it has got its own disadvantage of high risk of dislocation in the literature. Lateral approach, again saying that the rate of dislocation is less, but it comes with impaired abductor function. My few cases of lateral approach coming back to India from Germany, I couldn't find a patient who was not complaining of lateral thigh pain. Though in Germany they are all doing lateral approach and it was a navigated surgery, everything was, they would do good. But here patients sometimes are even they will complain of abductor pain. Anterior approach, early recovery and lower dislocation rates, but it has got a steep learning curve and the risk of periprosthetic fracture. If you ask of the evidence, there is no clear-cut data. There is inconclusive data to definitely support the superiority of one approach over the other. Because the basic main approaches, they were never compared. Whatever you are trained in, today, UK surgeons, UK trained surgeons, they are more in lateral approach. You go to UK, they are more familiar with the cemented hip arthroplasty. I was in Thailand 2-3 years back, just before the COVID, 4-5 years back. Even younger and younger patient, there was a surgeon, she said, I do all cemented hip arthroplasty. APAS President David Chun, all cemented hip arthroplasty. Australia, Ross Crawford, all cemented, excellent result. Today also, some days I see patients operated by Dr. Dholaki and these all things, the Charles prosthesis. Excellent, doing after 20 plus years, 20, 30, 35 years. We have reviewed few of them. And sometimes we get carried away with the literature. So that's the main caveat these days. DA surgeons reported 76% increase in their patients, while non-DA surgeons recognized 66% loss in patients in US. That will change. But what is the literature based on? Go for it. 26 RCTs, if you look for the pain, lateral approach is associated with a lower decrease in pain score. Lower decrease in pain score. While in the operative time, posterior approach is associated with this shorter operative time, because most of us are trained in posterior approach. All those surgeons were trained in posterior approach. Obviously, the approach that you are more trained with, more familiar with, you will do quicker. Blood loss efficiency, lateral approach is associated with higher blood losses compared to the posterior approach. 33 RCT, so that posterior approach is associated with the longer hospitalization. If you see the component position, not much of a difference. If you see the hip score, D has a shorter, better short-term outcome, but at the end of after 6 months to 6 weeks, 6 weeks to 6 months, there is much of difference. And quality of life, lateral approach had higher quality of life score changes compared to direct entry approach and the posterior approach. So, what is the ideal approach? Nothing ideal. You should have adequate visualization of the landmarks in every approach. You want to see that acetabulum by 360-degree view. You want to beautifully expose the proximal femur so that you can broach in. There should be minimum damage to the tissue, ease of implanting, have a stable hip at the end, and early return to the activities. Of course, the surgeon's comfort matter of much. You should be comfortable at the end while operating the patients. Going little away from that, you learned all approaches during your residency, you attend all these courses. Someone talks, this is better, someone talks, that is better, someone says. What I have learned at the end that you should also try to be familiar with the other approaches, because there are certain conditions where you find your usual approach being difficult in cases. Fracture neck of femur, bedridden patients, or say, lateral lying patient, have a bad bed sore in the lateral side. You don't want to go in that area and give an incision. Sometimes you have to change your approach accordingly. Fracture neck of femur, having ulcer area in the over the greater trochanter. You want to change it. And come the patient like this. In totally arthroplasty, you talk about deformity, just like in the knee. A patient with fixed flexion deformity of the hip, which is the most contracted structure, what is the first structure to get contracted to contribute for flexion deformity of the hip? Anyone? Patient has a flexion deformity of the hip. Anyone? It's the anterior capsule, the first structure that gets contracted. It's disturbed because pathology is in the hip. Imagine this patient trying to do a posterior approach and trying to do the anterior capsulectomy or capsulotomy from the posterior. It will be difficult for me. Had I been a lateral surgeon for this, it would have been easier for me. Because if I have not trained in lateral approach, it will be difficult for me to excise the capsule going from out. Or you have to go for a dual approach. You open the joint from the back, go anterior, remove the capsule, anterior capsule, and then come back. Second, see the patient, abduction, wide abduction deformity. Positioning the patient is one cumbersome thing. And with external deformity, you have rarely any excess between the greater trochanter and the ilium. And it's a bony ankylosis. Going from the posterior approach, either you have to eat some part of the greater trochanter to get access to the neck and to the neck osteotomy, or you have to change the approach. Either go for anterior approach or the lateral based approach. It will be difficult. From positioning to execution of the surgery, it will be difficult from the posterior approach. And again, the risk of dislocation is always there. Same, that I was telling. A patient with a history of septic arthritis of the hip and debrided from the anterior side. Because my contracted tissue, my goal tissue to remove is all anterior. All anterior. Yes, you can do it. You can remove the tissue, but with caution, precautions, get difficulty. If you go from the anterior approach, you can excise the incision and do the ridiculous anterior capsulotomy if you are going from the anterior side and excise everything. See the patient. If I try to do one approach or one hip from one side, the difficulty that I am going to get in these cases. Positioning itself is a difficulty. And executing the hip is difficulty. And if I try to do more of anterior in this, I will have really some access to this part. Posterior would be a better fit in this case. So that's why I am telling. And there's the same case. The opposite side, if you try to do in a one adducted and abducted one, you will have a fracture neck of femur in the other side. Also, I had incidents of spinal fracture while positioning the patient from supine to lateral position. Bony ankylosis. because you are not accessing the joint through your, the required approach, or say you are doing through that approach. Sometimes you can go more medial, you can make left, more upwards or downwards, and ended up in this condition. So what my emphasis is, if the patient has been operated previously through some approach or some part, try to get an access through that part. If there is some procedure has gone anteriorly, go anteriorly. Some process has been gone laterally, try to go laterally. And of course, if the procedure is posteriorly, go posteriorly. To summarize, any surgical approach that can achieve excellent outcomes is performed well. But you have to individualize the approach according to the need of the patient and your comfort. So try to be a circumferential surgeon by learning rather than being dedicated to only one approach. I'd like to thank you for your kind attention.
Thank you, Dr. Gautam, sir. It was a wonderful presentation. Any questions from the audience regarding approaches?
No questions. Okay, finish. The same delegates will continue in till 18th, right? Dr. Upadhyay? The same delegates will continue in Sion Hospital, right, in 18th? Because I got a message for 18th also. So there we'll learn more about the particular approach. There I'm going to talk about direct anterior approach with demonstration, right?
Next, I would like to call Dr. Vidyanand Raut, sir, for a topic on intraoperative challenges and complications.
Okay. Yes, sir. Yes, ma'am.
Okay, good afternoon, everyone. So I'm supposed to talk on intraoperative challenges and complications in hip replacement. So in your journey in hip arthroplasty, you're going to encounter challenges, you're going to have complications. As you become more and more experienced and you improve your training, these complications would go down gradually. It's important to be aware of what challenges you are going to face, especially so in the early part of your arthroplasty journey. And so this talk is going to give you a brief overview of the common problems that we see in total hip replacement. So, what can go wrong in THR? Inadequate exposure leading to problems, uncontrollable bleeding, fracture either in the acetabulum or in the calcar, difficult reduction, dislocation after surgery, need for ETO, nerve injuries, cement problems, bone cement implantation syndrome, and implant positioning, implant malpositioning. So these are the things which you are going to see briefly. There is nothing like minimally invasive surgery in total hip replacement. You create an exposure which will give you the best result. You don't need to struggle. If you keep a minimal incision small and like to brag that I have done this surgery in 6 inches incision or 5 inches incision, that's not going to work. If the patient is especially obese, you need to increase the exposure. Uncontrollable bleeding. So whenever you are doing any hip, whether it is total hip replacement or a bipolar, always reserve 2 units of blood. Can I have some silence, please? Keep vascular clamps and ties. And should there be any bleeding, just remain calm, pack the wound, call for help, ask for blood. Okay? Usually you will get out of the problem. The bleeding usually occurs from the circumflex vessels. And in addition, there would be generalized oozing as well. So as I said, you should have blood reserved, regulate the blood pressure, get your anesthetist to be aligned with what you are doing, which step of surgery you are in. Stop blood thinners before surgery. Local and systemic use of PAWS or tranexamic acid. Careful attention to hemostasis before wound closure. And consider the use of drain if there is a generalized oozing present. So with all these techniques, you should be able to take care of generalized oozing. Another common problem is calcar fracture. So what happens is that when you ream, when you start increasing the broach size, sometimes there is a calcar fracture which may need you to use a calcar wire. Usually most of the times the crack is minimal. It does not propagate. It usually remains proximal to the lesser trochanter most of the times. And it is easily treated with the help of a cerclage wire. So you have to be vigilant when you broach. The other end of the problem, the acetabular blowout or medial perforation will occur when you ream too much. And you ream, and you find that one of the columns have disrupted, or you have broached the medial wall. So you have to be careful, and this is where preoperative planning comes in. You should know which direction and how much you are going to ream or broach. Difficult reduction of trial components. So basically, you have to play around with the depth of insertion of your stem and the biomechanics of the hip using the neck offset and the neck length and the offset. If you find that even the shortest trial you are not able to reduce, then what you can do on table is you can do a release of the inferior capsule. It's very easy. You can release partially the gluteus maximus insertion on the femur. That will create some laxity. And in certain cases, you may have to release the iliopsoas. So with the help of these techniques, you should be able to get the hip down and at least get the shortest neck inside the hip. Dislocation. So it's important to do a stability check when you are doing the trialing components. You have to do the shuck test. It's very important. You get the hip after reduction, you get the hip through the entire range of motion. See to it that there is no impingement. See to it that the soft tissue tension is good. See to it that it does not dislocate within the normal range of motion that you expect after surgery. Closure should be in 2 layers. In total hip replacement, I go by the posterior approach. I always do a separate capsular closure. Whatever fragments of capsular tissue I find, I close them separately. And then I go for the Ranawat style stitch where transosseous sutures are required to close the posterior wound. There is also an approach described called the piriformis sparing approach. I don't use it a lot. I've tried it a few times, but it doesn't work well in my hands. Maybe Deepak has got something to say about it. Okay, so to impart stability, we may increase the head size from 28 to 36, or 32 or 36. Usually you don't need to go up to 40. Or you can go for a slightly more constrained options like dual mobility or actually a constrained liner of the hip. So these are the options that are available if you feel that the hip is going to dislocate. And most important, when we check for stability, we have to do the combined antiversion test. You look at how much is the effective combined antiversion of the acetabular component and the femoral component. See to it that when you make the hip internally rotate by 45 degrees, the equator of the femoral head and the equator of the acetabulum are coplanar. And as I said, these are the tests for stability that we do. Another problem that you may encounter is an unexpected need for ETO. Like when you can see, I was revising this Indian implant, which was a total hip replacement, and absolutely no indication during surgery. When I tried to extract the stem, only the proximal part came out. There was a fracture which is not seen on the X-ray. And then it was cemented. How would I get out the lower part of the stem? There is no way except for an ETO. So how many people are aware of what an ETO is? Have you seen an extended trochanteric osteotomy? Yeah. So it's a lateral splitting osteotomy to approach the proximal part of the femur. And you should be trained for it. It's not a very difficult surgical technique. And all it requires is an osteotome, 3-4 osteotomes, and a good cerclage technique. Okay? But it is a bailout situation. Post-op lengthening and shortening are two common problems that we see. Both are bad. As you can see in the X-ray on the left, the stem is too proud, and obviously the patient would have lengthening, possibly even sciatic nerve palsy. The other X-ray, the stem has sunk in, so the patient would have shortening. So it's important that you stay within a few millimeters of your intended limb length. Preoperatively, you have to measure if there is any lengthening or shortening. Post-operatively, you measure it yourself. Don't let the physiotherapist do it, because their failure, they will blame it on you. And a very good technique which I like to follow is intraoperative assessment. After I dislocate the hip, I measure the vertical offset and the horizontal offset using just a scale. It's a crude method, agreed, but most of the times it will give you a fair idea of how much offset you are going to need and how much, what is going to be a depth of insertion and your limb length. Another technique, this has been the classic Ranawat paper, Dr. C.S. Ranawat has described it. Using a Steinmann pin in the infracorticoid notch, you can assess the level of placement of the hip, of the femoral component with respect to the acetabulum, and so we can check for post-op lengthening or shortening. This is how you do it. Next we come to sciatic nerve palsy. Now, when you do the posterior approach, this is not a problem with DA, this is not a problem with lateral approach or hard hinge approach. So specifically for people who do a routine the posterior approach, most important, avoid lengthening the limb. If you lengthen the limb by more than 3 to 4 centimeters, you run the risk of stretching the sciatic nerve. Okay? Stay close to the bone. If you are doing the posterior approach, there is about, the nerve is about 3 centimeters away from the bone. And 3 centimeters, believe me, is like 3 miles. So if you are careful, if you use a cautery and stay close to the bone, you will never damage the nerve. By using cautery, obviously, if you are straying too close to the nerve, you will get a jerk. Okay? But more than the cautery, what is important is apply the retractors carefully. You apply the retractors yourself. Sometimes with a right angle retractor or a spike, you can have a pressure on the sciatic nerve, and in the lengthy surgery that can lead to a sciatic nerve palsy. Always be aware where the nerve is, where you are working and where the nerve is. And you have to be extra careful in obese patients, in dysplastic hip, and in protrusives, and obviously in revisions. Cement setting early. So nowadays we operate in good operation theaters. The temperature is well maintained. We have a laminar airflow. So this problem is rarely seen now. But believe me, I have seen my fair share of cases where I was called in to tackle these problems. Someone had done a bipolar in a nursing home, and in the nursing home the temperature is not maintained properly if there is no air handling unit or the laminar airflow in the system. So the cement set very fast, and the surgeon could not insert the implant completely into the bone, could not reduce the hip. So you have to regulate the OT temperature. You have to keep cement in the fridge for as long as possible, and use a familiar type of cement. Whatever type you want, Smart Set or Palacos or whatever, use a familiar cement. which you know how to handle. Cement mantle is important in the UK, as Dr. Deepak said. Lots of cemented total hips are being done. Here also, most of the bipolars that we do are cemented, though the THRs are more and more uncemented now. But you should be good at cementing, both the acetabular component and the femoral component. So you should aim for a good cement mantle, good pressurization. On the right, you can see an example where there is a bad acetabular cementation. I mean, you have to avoid such things. How many of you are aware of BCIS, bone cement implantation syndrome? Yeah, so what happens is that it's a very rare phenomenon, but because when you mix the two components of the cement, the liquid and the powder, the unpolymerized monomer, which is in the liquid stage, sometimes that can get into the circulation because of your pressurization. And because of this monomer, there is a sudden drop in the blood pressure and a sudden drop in the saturation. Believe me, this is a very catastrophic event. It has happened to me once and I lost that patient. Okay? So you have to be on top of it. You have to deal with it. Before cementing, you have to tell the anesthetist कि बाबा हम लोग अभी cement कर रहे हैं. Tell them to raise the BP slightly. Keep it at 130, 140. So even if it drops, if it will drop to 90 or 100, it will not come to 60 or 40. Okay? So they usually prefer to give an F-Corlin or a Dexa injection just before cementing. They usually prefer to put the patient on oxygen when you are cementing. So with all these techniques, the incidence of BCIS can be minimized. And you have to use third generation cementing techniques, the pressurization technique. You have to use the cement gun. You have to vent the canal. You have to see to it that the cementing is done properly. You want to have a good cement mantle, but without all the complications. Implant positioning. So, it's very important in all total hip replacements that you get your femoral and acetabular components at the place where you intended them to be. Preoperative planning is essential here. On one side, you see a good positioning of the component. On the other side, you know what is the problem that has occurred? A reaming has been done with a smaller reamer, which has gone more deeper, and the acetabular component has not seated well. Okay? So this is bad. It can lead to an early loosening and failure. Lastly, we come to a problem which can be easily avoided. You should not get caught with shortage of instruments and implants. So the instruments that you commonly need are different set of osteotomes, nibbler, bone gouges, 2 or 3 hammers, stainless steel wires to deal with an unexpected ETO, wire passers, nose pliers, different sizes of right angle retractors, especially in obese patients, different sizes of spikes or homons, broken screw removal set, a scale, because we are measuring all the time, a scale, and a trauma set with 3.5 and 4.5 screw systems. All these things have to be there in every THR that you do, however simple it appears to be. Regarding implants, personally check the implants. If they are there in the OT before you start the case. Before the patient is induced, see to it that all sizes, all possible required sizes are there. Whenever you are doing an uncemented THR, always keep cemented system as backup, because that can be a bailout situation. And as I said before, use a familiar cement. So, most important, how do you tackle these problems, or how do you tackle these surprises? By being prepared. So by being prepared, you can have a good exposure, you can control the bleeding, you can prevent an acetabular fracture, a calcar fracture, you can, most of the times, you can prevent dislocation. You won't need an ETO if you are prepared for it, and you will have a good limb length without any limb length discrepancy. You will not get a sciatic nerve palsy. You will not run into cement problems, and you will not run into implant shortage. You have to be prepared. And this preparation has to become a habit. It has to be done in every patient, in every case, whether it's your first THR or 1000 THR. Thank you very much. So,
Thank
any
you, sir,
questions I would be happy to answer. No questions. Okay, thank you for your patient hearing.
Next, I would like to call Dr. Savan Kumar for his presentation on acetabular preparation in total hip replacement, pearls for secure fixation.
अच्छा इसमें ये चेंज किया ना समीर सरांचं माझ्या ह्याच्यात इथूनच आहे Okay, good evening everyone. So I'll be talking about the acetabular preparation in total hip arthroplasty and pulse of fixation. So basic important factor for good THR is acetabular preparation, and it's a critical step for successful outcome. So goal of the THR should be like optimal implant position. So is to achieve the stable and durable fixation, then restoring the hip biomechanics. So the challenges for the hip in THR for acetabular cup placement will be like the bone quality, anatomical variation of the bone, and the implant selection. So basic anatomy, like acetabulum is compromised of the three bone, ilium, ischium, and pubis. The cartilage and labrum, they are the key factors for the joint stability and the load distribution. And vascular component is like superior gluteal artery and obturator vessels. And the landmark for most of the followed for the cup placement is acetabular notch and transverse acetabular ligament. So pulse for acetabular fixation, now ideally like Levenick zone, like considering the achieving the optimal implant positioning of anteversion of 15 to 20 degree and inclination of 40 to 45 degree. Ensuring the good bone contact with the implant for better osteointegration and cement fixations. And it's also important to preserve the ideal bone stock while removing the cartilage and debris, and it's not to break the medial wall. So, and also to avoid the minimal complications like loosening, impingement, or dislocations. Approaches, as we already previous talk, we have seen like various approaches: posterior, anterolateral, direct. And whichever the approach you take, the important factor is like important positioning of the cup. And the landmark should be visible in whatever approaches you use it. So the key steps in acetabular preparation is the first important step is like adequate exposure of the acetabular, 360 degree you should be visualized. So you can place your retractors and homons adequately. Then the reaming should be like very like adequately, gradual reaming should be there. Initially the medial reaming should be there to remove the to reach the bottom of the acetabulum, and then gradually start with a smaller reamer and progress incrementally depending upon the size of the head. And aim is for the hemispherical shape with good bone contact in anterior-posterior capture, and also the toggle like anterior superior-inferior. So trial of the implant, it should be like assess, you should like, it should be move easily, the component should be fit enough, and it should not move with 2 or 3 finger test. So once you are doing, like you can see, like in this picture, like intraoperative peaks, this is like posterior, anterior, and superior. You can see the inclination almost achieved like to around 35 to 40 degree with a version of 15 to 20 degree. Press fit fixation, like how we can achieve the secure fixation technique is the like press fit fixation, where you can see for adequate rim contact, you can undersize the cup by 1 or 2 mm, and you can just augment the cup with the screws in cases of osteoporotic dysplastic bones. And usually you should follow the safe quadrant zone, mostly posterior superior and posterior inferior, for the screw fixation. And third, like if there is a like elderly poor bone stock, you can go for the cemented cups. Fixation method, like for cemented, you should like prepare the bone preparation. It should be a dry, and it should be a rough surfaces, and there should be a cement pressurization for better integration of the component. And in cementless cups, there should be a press fit technique for initial stability, and porous coated implants are available for good bone osteointegrations. Hybrid is you can use in the complex cases of dysplastic hips. Pearls for secure fixation, they ensure the full rim contact, particularly anterior-posteriorly, and avoid over-rimming or eccentric rimming. While rimming, you can feel the feedback like crater feeling during the rimming and confirm the stability while the push-pull test. And don't hesitate to use the supplementary screws for adequate fixation. And in complex spaces, consider the augments, bone graft, and custom implants. Common pitfalls and how to avoid them. Pitfall like mostly like malpositioned cups. Avoidance tips like use the transverse acetabular ligament as a landmark for positioning your component. Thin medial wall, just avoid the excessive rimming medially, just to avoid the medial cortex break. Inadequate rim fixation, you can just undersize and improve your rim contact. And you can also check this cup togglability or instability. In that time, you can just add additional screws and reconsider the cup size for the better fixations. Pelvic discontinuity, just go for the custom-made implants and augments. The summary, like acetabular preparation is like a basic step, and it's a critical step for THR for better secure fixation. Key pearls is like precise rimming, optimal cup orientation, and strategic screw placement. Addressing the challenges like bone defect enhances the outcome, and meticulous technique will prevent the early failure. The longevity of the hip replacement often rests on the foundation you prepare. Yeah, thank you.
Thank you for the wonderful presentation. Any questions from the audience, please? Next, I would like to call Dr. Sanjay Dhar sir for lecture on avoiding the uneven gait, practical tips for lip length discrepancy in total hip arthroplasty.
So you have had a few lectures about the total hip replacement approach. This is something which we all encounter. In fact, I have, in last 1 year, I must have lengthened at least 2 of my total hips who are constantly pestering me that when will this length become equal. I always give them hope that it will become equal over a period of time. So that's how you avoid leading questions. So what is the aim of a normal total hip is restoring the normal biomechanics because you are replacing the joint. So to restore the normal biomechanics gives you the feeling of a normal hip. And hip is a very sensitive joint, and of course it's a very mobile joint, so the results are excellent once you do a good total hip replacement, but it's also a sensitive joint where biomechanics does real matter You might have still an abnormal lurching gait after a good TH. If your abductors are not well tightened, lengthening may be a problem, or it may be too tight. So flexion may be restricted, adduction may be there. So it's a goal, it's a balance between seesaw between the stability and the length. So if you restore the length adequately and your stability is good enough, that is probably a good, well-done joint. So dislocation or instability is very common. 2% of patients dislocate within 1 year. Primary hip replacement dislocation ranges from 0.2 to 10%, and revised hip can be as high as 28%. So dislocation remains still a very unconquered result in case of total hip replacement. So limb length discrepancy, the incidence again is almost 1 to 30%. You may not have noticed it, but if you really measure and actually audit your result, there may be a good amount of them who are having limb length discrepancy. So, but luckily up to 2 centimeters is well tolerated, so patient doesn't realize it. And if it is greater than 5 millimeters, it may be associated with patient dissatisfaction. So patients will keep asking you that they feel, they may not be able to identify it. You may be able to identify it, but they may not. But they will probably show you some signs of dissatisfaction. If it is more than 10 millimeters, they lead to mechanical discomfort also. So they have worse Oxford hip scores, there may be some limp, then there may be arthritis starts, knee arthritis, the other knee may start giving symptoms. So they do get symptomatic and they probably need management. So functional limitations, patient dissatisfaction, make leg length problems most common cause of acrimony. It is not very common in India to get litigation. We had some big case not long ago in Lilavati. But generally, we don't still have cases, but internationally, it is a very high cause of litigation. So it's very important you sort of be aware of this and try to make it little as minimal as possible. So it may be anatomical or it may be functional. Functional means patient still has that feeling of some leg changes because they had earlier problems. They might have LLD prior to surgery, so they might still come with feeling. But over a period of time, they will become normal. Functionally, it will improve over a period of time. So then some people still have that sensation of, so if your gluteus is tightened, you might still have that sensation of lengthening, although your patient's length may be equal, but they will get that feeling of tightness or sensation of limb lengthening. So you have to identify, so a good clear examination pre-operatively as well as post-operatively is very important. Anatomical means structure, so there is lengthening, so that you have to identify. So preoperative limb length becomes very important. So in counseling, you have to really actually check preoperatively that you have measured the length, and fortunately or unfortunately, there is a very large percentage of patients who have actual limb length discrepancy prior to the surgery. You may not notice it, but if you really measure them to quantify it, they will have some LLD. So generally, if it is like an AVN or an arthritis, you will have almost 3 millimeters to 5 millimeters shortening, which is accepted because of the cartilage degeneration and something. But if you really measure it, some of them may have limb length. It may be fixed because of pelvic obliquity, or it may be because of inherent limb problem. So that you have to identify. So you should have a prior functional limb length measurement, whether from the umbilicus to the medial malleolus, or you may measure the true length. If so, generally in case of THR, we measure the functional limb, which is from the xiphisternum to the medial malleolus. So any perception of patient's perception, as I told you, it has to be quantified. You should note it down, and it will help you in counseling the patient. So any soft tissue contractures you have to identify. You should see that there is any adduction deformity, abduction deformity, or flexion deformity. So you should quantify it, write it down somewhere, and use it in your counseling so that you can at least post-operatively be able to explain the whole thing properly. So conventionally, it was you need to measure it. You can put blocks, which is a very conventional method. I don't think we have blocks available. But then you are able to see that once you put those blocks, you will be able to see the balanced ASIS comes to the level, pelvis comes to the level. So you actually can reveal the deformity. like we do in adduction and abduction deformity, we reveal the, so here if we put the blocks, we'll be able to reveal it and see that it is a functional limb length deficiency. So prevention, preoperative patient history, physical examination, as I tell you, is very important in these cases. In hip, you should always measure limb length, quantify it, note it down on your OPD papers, and see that if it is any extra articular or an intra-articular or a below hip deformity, which is there, which you can quantify. Then sitting and standing X-rays, because if you want to reveal the deformity, it is a functional. If on sitting it will be neutralized, you can see that it is a functional, which obviously gets corrected once you do a proper THR. But if it's a fixed deformity, then you need to identify whether there is spinal deformity, pelvic deformity. So you'll be able to, because patients otherwise might accept that his whole gait will change and he will get normal gait, then at least you can be able to tell them that this is a fixed deformity, you will not be able to correct it. So sitting, standing X-rays do become important in such cases. Then something pelvic obliquity, which is, I'm sure, it's not a very important, it's very easily detectable, but we should be aware of that, whether it is an oblique pelvis or it is just a functional pelvic obliquity which disappears on sitting or recumbency, or if it is a fixed pelvic obliquity which cannot be passively covered. So standing X-rays, again, as we do in TKR, we should do in THR also. They have many advantages. You can see that length, you can measure the, if you're not able to get the blocks, at least you can ask your radiologist to measure the lengths on both sides and see that there is any inherent underlying structural limb shortening. And then you can also see that whether it is correctable or not correctable. And then you can see the whole femur in the same view so that there is no any deformity in the distal femur. So this becomes very important. So as a rule, I think we talked in the preoperative assessment module also that we should take full length X-rays as preferably scanograms also. So measure the functional limb length discrepancy. As I told you, if you don't have blocks, you have not measured in the OPD, you can measure it on your X-rays. So then comes to the various points. So radiographic evaluation of limb length discrepancy is very important. So identify, I am sure we'll talk about in the modules also, that teardrop. I think all of the speakers showed you what is teardrop. So it becomes very important. Teardrop has a very important role in total hip replacement. So you should identify the teardrop on the X-rays, as well as you should be able to actually correlate that teardrop in the hip also. So it is just inside the tal on the medial side, just above is the actual anatomical point of the teardrop. So your cup should be somewhere around the teardrop. So that is what you should measure. So on the X-ray as well as the intraop, I don't know, in this presentation there's not, I had actually tried to mark the teardrop in that slide. So that teardrop in the hip also you should be able to intraoperatively be able to identify. So that is somewhere, that's not a very pointed point, that's not a very anatomical point there, but you can see it just below the tal on the medial side, you'll be able to. Then lesser trochanter. So take good views. You should see both lesser trochanters on the same profile. So pelvis around 20 degrees of internal rotation, that is the X-ray you should take. It should not be that you have told the radiologist to the X-ray, one limb is external rotated, one internal rotated. So they should be both in same position, 20 degrees of internal rotation. Then only you can do all these measurements correctly. So identify teardrop, identify lesser trochanter, tip of the trochanter, pelvic, this acetabular rim, all these points should be marked, ischial tuberosities, and see the profile of the obturator foramens is equal on both sides. So that means your pelvis is well balanced. Your ischial iliac crests are at the same level so that your pelvis is well balanced. So then mark, some people have softwares, others if you don't have, you can do it on your proper personal computer also. So standing AP of hip, knee and ankle on the same view, femoral offset neck shaft angle should be marked. So you should, that is the center of the head you should mark, center of the tip of the GT, as I told you, lesser trochanter, midpoint, and then axis of the femur. All these points you should be well aware of. So measure these points, measure these lengths on your X-rays, and then you can quantify them and write it down somewhere preoperatively, and so that this helps you in also templating the neck. and deciding the size of the implant. I'm sure there was a lecture on templating, and they will talk more about that. Then antiversion. So if you are taking offset, a different antiversion also it changes. So if you have a normal antiversion, that we consider it normal around 15 to 20 degrees. So your measurement offset will be different in different antiversions. So you should identify clinically that how much offset, how much of antiversion does have. So prone examination as well as supine examination, see what is the real antiversion, whether it is very antiverted hip or a little neutral antiverted hip, then your measurements will vary. So you have to keep all these in consideration so that when you are doing a total hip, ultimately to get the length and stability with these parameters in mind becomes much easier. So templating is, I was talking to somebody in the module also, that templating is important, although earlier during my younger days we used to get templates essentially with the implants, but now they are not available. But you can ask, every company I think has templates, only that you can force them. Particularly the youngsters, they should do it. Somebody who is doing total hips recently, he should always try to get template, because one, it can give you a fair amount of the size, whether you need a 50 cup, you need a 48 cup, in the stem size. As I have said, I told somebody that while you are doing a THR, you are not very sure how much reaming you do. There are parameters, there are guidelines that you should see the floor, you should see the articular surface should be just denuded, you should have punctate capillaries, which probably tells you the size of the cup. But you can imagine a variation, like you have seen this at 44 reaming size, but your template is showing you 50 size. That means there is something wrong. You are under reaming, or you have not reamed properly in a proper direction. You are doing it in a single direction. So that is what gives you a fair idea. So if you have a templating done and you have found that your cup size is 50, then if you are ending at only 44, then there is a huge variation. Only a cement can fulfill that. The gap. So if you are doing an uncemented hip, you need to be very close if your templating is correct. So only problem is that you should need a normal regular size x-rays. So your radiologist or technician has to be compliant in that to get that. Many people now have digital x-rays, but they don't bother to give you regular size x-rays. So templating is important. So you get a fair idea of your stem size, your cup size, your offset, how much offset you need to get. So that becomes very important. So when you're trying to get the length proper and stability and balance between stability and length, then these things are important. So measurements like from the center of the head to the lesser trochanter midpoint, the parallelity of the ischial tuberosities with the center of the head, the GT centers, if they are all matching on template and you are getting a proper size, that size you have to try to achieve while doing the surgery. So these templating, there are now digital templates also available. You can, some hospitals do have CT-based templates also available. EOS, they allow that if you have, but wherever it is not available, at least try to get these parameters done and traced. You can even use a trace paper. You can take an X-ray, use a trace paper. We used to do it in good old days in Sion. We used to get tracing and make a tracing of the cup and then try to see that what is the size of the cup. So do that, particularly youngsters who are starting it becomes very important. So once you have templates, it's a two-dimensional templating. And although it is not very reliable, but it ensures equal lower limb length. You can see that how much length will change and all that. So in getting a proper limb length, it becomes very important. So ask your company fellow to get it, and at least initial few cases you can do it, and you can get a fair idea. You will be very satisfied once you do that, and it matches with your ultimate operative result. So 3D based CT templates, some hospitals do have, they give you a lot of information. You can even take lateral X-rays and see the center and mark the offsets with this. But I'm sure many hospitals don't have this available. So this is a more accurate method where you can see the position the stem and position the center of the head, center of the neck, and both AP and lateral, and see how much length changes with them. Now we have robots. Wherever it is available, I think that is probably the most accurate method where it sees the functional length as well as the center of rotation, and all that can be done with robots. So anybody who has a robot can probably get more It can give you projected length, projected size, everything probably gives that. I have not yet used a total hip robot, but there are reports as well as people have told me that it gives you very, very fairly accurate cup size and stem size. So preoperative templating, you measure femoral head diameter, SLEP, cup. So even once you are excising the head, you can see that generally we add around 6 millimeters to the femoral head. That is your cup size. So you can get so use every other method to extrapolate and then get to reach the sizes. So if you have real proper sizes, probably your limb length will not change. So medialize the inner table. So that is another So the more you medialize, more your length shortens. So you need to increase your neck size. So that I'll talk in the next slides. So whether you are lateralizing the cup, whether you are medializing the cup, that will change the limb length. So now we use these modular cups and hips. So they are almost 6 millimeters thick from the inner side, the inner articular surface of the cup as well as the posterior wall. So it's almost 5 to 6 millimeters. So that much length you are achieving by, it is not the conventional cups where we sort of sink it inside. And so you have to account that length somewhere in the neck as well as, so femoral cut, the medialization of the cup, that becomes very important in such cases. Now there are papers where they say that lateralization is more helpful. It gives you a more functional hip rather than medialization. Conventionally, we always try to touch the medial side with the collar line, with this. We try to see the floor and try to put the cup as medial as possible without breaching medial wall. So templating I'll probably show it in the next slide. So cup angulation, that also changes. So your offset changes with your angulation, medialization. So all these things conventionally 45 degrees, medial wall touching collar wall, and neck size almost 10 millimeters. This gives you regular length, but you need to change it if you are preoperative. That is why I said preoperative assessment is very important. So this is something what is called as combined offset. It is the vestibular offset and femoral offset. So you have to measure both. We generally measure only femoral offset. So that is what I said. How much you medialize as you go closer to the collar line, that will change your length. So that is what is called combined, is called as global offset. So from the medial collar line to the axis of the femur, where the tip of the trochanter, that is something called the axis. So the length, if that is changing, that is increasing your length or decreasing your length. So try to match that with your preoperative template, or at least try to account for if there is shortening prior preoperatively. So this is what is called as global offset. So this has to be matched. So your cup, see, you can see in that cup, I think this is my own case. So this cup is more lateralized. So there is that much amount of lengthening happening. So if you assess your x-rays, you will probably be able to see it. So if I would have touched it to the medial wall, which is conventionally the ideal method, I would have reduced some length. So if there is some lengthening, that is because that is the one of the reasons. So, and then version also it changes. So if you feel that we have got a good femoral offset, it may not be correct. So you have to see global offset as well. So what we do is we always write it on your this drapes. We measure it preoperatively as intraoperatively, then write it down. So use anything. You can use cautery, you can use scale, you can use a tape, you can use a thread. You can tie it to your vestibular pin there, and then see the length and keep it hanging there, and ultimately check it. So nothing is very perfect method, mathematical method, but then you can keep on doing these methods. So selecting the right femoral empron, I'm sure Dr. Yadav will talk to you about the stem, proper stem, but whether it is your prior hip is in coxavara, you can see this. If you have used a normal 135 degree stem, the gluteus is relaxed. So then if you increase the offset, so you will have normal, but then you will increase the length. So that is why you need to sort of match it, a preoperative assessment, whether see your neck shaft angle preoperatively, how much that you should actually write it down. And even I don't do it now, but we should do it regularly. So whether you have a coxa vara or a coxa, sorry, that is valgus there. So if you have preoperative valgus, so if you increase your vertical offset it will change the length. So all these things do matter in these cases, and it is very important that you are aware of these things and you know how to change your offset and accordingly, and you should tell your company fellow to keep these offsets available on the table. So this I'll skip. Dr. Vikram is talking about this later. So we generally have 4 goals, whether we should have. So I'll talk directly to the technique. Are there any technical tips? So I think we talked that your patient should be very rigidly fixed. If you don't have your table accessories, like many hospitals, nursing homes may not have, so take whatever it takes to fix the patient to the table. So this is what we used to do not long ago when Apollo had not allowed me to do cases here. We used to use pillows, everything to tie them very rigidly to the table and so that they wouldn't move. If you have good table available, accessories available, you can do, but see to it that your table is well fixed, and surgeon, it is responsibility of the surgeon that he has seen it before draping, that his table is well fixed and it is 90 degrees to the floor. So do that preoperatively, otherwise, and then check the length. Of course, this is not a very accurate method. You see the length of the knees. You can put this ECG lead tip on the patella and then see that. Once a patient is in this position, the surgeon himself is going to check whether how the knees feeling is there, the length, whether this length is shorter, longer, the ankle, malleolus, heels. So try to put them in the same position and then see the length, what you are going to later feel under the drapes. So people use these ECG leads at the tip of the patella and then try to feel that under the drape and then measure the length. So you can do that. But I am sure nothing is I have tried it so many times, but I am not 100% correct all the time. But then these are methods which you should use, and they definitely do help. At least they'll give you a fair idea what is going wrong or right. So good exposure of landmarks is very important. So don't try to avoid exposing properly. So see that your tile is well visible. You are feeling your spike is below the tile. Your supraestibular area is where you are going to put your chain and pin. That is well exposed. So Ranawat method is that he puts K-wire under the tile and then tries to measure that. So if you're doing that, you do that method properly. Don't just skip the steps. Then you can do marking of the greater trochanter tip, so that marking of the lesser trochanter midpoint, which you are going to measure as offset. So do good exposure, release the capsule properly, and see that all your points which you are going to use as measurements are well exposed. So this is the green is where you will put your pin, chain and pin, and that is the hip. I have superimposed the textbook picture on that. So your well exposed, and then you can think of measuring them. So this is where these points you can mark. For measurement. So good exposure is very important in these cases. Then again, you can do the measurements intraoperatively. So these try to measure these and write it down on your drape so that you can replicate them later. So this also gives you the idea where you should cut your increase or decrease, that should be done and decided on table. So this is how you take these different measurements and neck cut. So plan this. You might initially take a little higher, longer neck because if there's already pre-existing shortening, you can probably further change it. But if you prior take a very low neck cut, you are bound to get shortening, or you might need to add a lot of. So that offset, if you keep on just by adding neck, it changes the whole offset also. So try to get it as near to 135 degrees of the neck angle, unless there is a prior preoperative varus or valgus head. So this is the measurement from the tip of the trochanter to the center of the head. Write it down somewhere and see that how much post-operatively, trial implant and preoperatively how much you have to measure. You should try to match it. You can take it out also and take it from the corner of the neck also. That also gives similar result. And then other is vertical offset, which is from the center of the lesser trochanter to this. So this height and this height, this is the horizontal. And then from your floor to the final, the template, the trial component, you can see how much of the thickness is there. So try to add this and you will probably not get lengthening or shortening. So as I said, good exposure, you can see the whole rim is exposed. So your position, and then the pin is here somewhere in the top, which is there, and then you can again measure the length and see that there is circumference. So your cup, if you are changing the position, I use all the walls as the reference guide how to position my head. So, so tile is here. So it is generally said that your 45 degree comes if your inferior margin is flush with the tile. So if you are going 5 millimeters inside, you are changing the angle from the top. So if you are going 5 millimeters out, you are more vertical. So that is what always try to aim. See, the tile is very visible. It's very prominent structure there, and probably that is the only structure which is anatomically seen there in most of the cases. So position your, at least for the trial, you can use a smaller trial initially and see that it is sitting flush with the tile, and then all the walls. So if you are seeing some abnormal exposure of the wall or the cup on any wall, that means something is somewhere wrong. So at least anterior margin, inferior margin, superior margin, they should be matching. If your posterior margin is little proud, you may still accept it. But generally, at least 3 of the margins should be in well position, good position. So these parameters also change your length. If you have made your cup very proud, if your cup is coming out of the tile or coming out of the anterior wall as well as the superior wall, that means you have gained length by under-reaming or probably using a bigger cup. So coverage on all sides is very important. You can see that tile, it should be flush with the tile. So if your tile is matching, then generally everything, unless there is a deficient wall, the anterior wall will also mature if there is no anterior osteophyte. So neck length adjusted until leg length equal, so you can keep on adding the neck length. So these days every implant is a modular implant, so you can use them. So check coverage in all positions. So if your length is changing or your offset is different, your neck shaft angle, if you put a varus stem or a valgus, your offset may also change. So be sure that is why reaming becomes very important. So if you have made the size of 12 in the template and you have done 12, that means your neck shaft, the stem is centralized. If you have used only 9 size or 10 size while you had templated 12 or 14, that means something, either it is in valgus or in varus, there is something somewhere is hitting. So again, your length may change in such situations. So ultimately, this is what you should get. You should get something on the center. They should be matching. Your angle should be 45 degrees. It should be flush with the tile here. It should not be deeper to this, what is called as teardrop. And the angle should be 45. So all these parameters, the lateral wall, the rim should be almost flush with the rim. So don't make it more horizontal or vertical, otherwise your length may change. And if your stem is well fitting, you probably would be in a good position to have normal length. So intraoperative landmarks, tests have been, these are all shuck tests. You just pull it and see that if the whole pelvis is moving or there is a lot of distraction happening, that means it is unstable, you need to add length. Then drop kick test, where you ask them suddenly flush it, as if it is giving a kick, that means it is little tight. And leg to leg comparison, which I told you, in lateral position, see the points, patella, ankle, heel and medial malleolus, if they are matching, probably your length is equal. But these are all very, they are not very trustworthy tests. So don't depend truly on them. That is why your offsets and other things become very important in such cases. So using a stable pelvic line, now there are so many methods which have been, we have also used some of these methods, but again, this is not available, I think, in India, where they use there's a that called tensioner, which you can add and see the length. You may use a K-wire and then match it with your K-wire, supraacetabular K-wire, and see that, but I don't know, I don't use them. I don't like putting anything in the proximal femur while I'm doing a total hip. So sometimes you need to change, so where your hip center is very offset, some revision hips, you might need to add length. So that is, again, you need to increase your offset. So again, offset, you need to vertical offset. We increase the offset to get more stability and proper length. That's all. Thank you.
Thank you, Dhar sir, for a wonderful presentation. Any questions from the audience for Dhar sir?
Good afternoon, sir. Sir, instead of lateralizing the acetabular component, if we use a higher offset stem, will that help in maintaining your global offset?
Higher offset, if your cup is horizontal?
No, in that one X-ray in which you showed that you had lateralized the acetabular component, and you said that initially we would always try to medialize.
Lateralizing the cup is a new theory now. They say more laterally, gives you better range of motion, because even in dual mobility, you are actually lateralizing the hip center.
But sir, then
that is why it is giving you more mobility.
Okay.
Conventionally, you have been medialized.
Yes, sir.
But that gives good stability, range of motion. So if you have a skirted hair, you have very thin obese patient, will hit it, so chances of dislocation are more. So that is why lateralizing the hip gives you more mobility. There's less chance of dislocation.
Sir, but then instead, if we medialize it and use a higher offset, would that also do the same thing, or it would do a different?
Higher offset will make it shorter, I think.
It will give more space for movement, no? The angle will.
No, that is, offset is basically stable. So you should match the normal offset.
Okay.
To the opposite side.
Okay.
So, but in some cases, like in valgus, or in varus, the reverse happens. Change the offset, the whole thing, length of the change.
Okay.
Measure the offset as compared to the other side. But in certain situations, like if you have a plastic offset is very low.
Yes.
But if you use the high offset, you might get dislocation.
Okay.
Or even in vertical cups, if you use high offset, there is a lot of wear. So that is why you need to see stability at what offset you are getting.
And sir, in which cases should we use a closed cup? Where now we spoke about keeping the angle at always 45 degrees. In what cases should we use a closed cup for a THR?
Closed cup means horizontal.
More horizontal, more than 45.
Protrusion, maybe you can keep more horizontal, and chances of when there is superior defect. So again, you might get horizontal is more stable, but it is
range of motion.
Horizontal is more stable, but then the least biomechanically the best position.
Okay. This cup positioning is by CT or by X-ray only? You are talking about this cup positioning.
By X-ray.
This is by X-ray only, right? That could be the new 40 or 45 that we are talking about. You understand? Because how you take X-ray is also very important.
Thank you, Dhar sir. I would like to call Dr. Vikram Pavade sir for his talk on preventing dislocation in total hip arthroplasty.
Okay, so I got the slides from Mr. Dhar. and we'll have a repetition of the same. So hip dislocation and how to prevent it. Let's see how much you have learned from it. 2% of the total hip dislocation and 24%, but the number could be much more than this. Because according to the Miller's textbook of orthopedics, 80% of the revision hip over the age of 80 are bound to dislocate. So it's a huge amount. So the next thing will be, what is the best criteria to avoid getting into this selection? So choosing your patient wisely. So advanced age, accompanying neurological disease, and impaired compliance should always be taken into account when you are going for a hip joint replacement. So we have talked again about suboptimal implant position, insufficient soft tissue tension, and inadequate experience of the surgeon, but that improves with the time. Now this soft tissue tension might be the most important thing in a geriatric population where the gluteus medius must be just like a parchment membrane. So now there is a renewed interest in iliopsoas transfer to GT, like the old people who have done the polio, like Mustard and Sherard's procedure. They used to transfer gluteus medius or iliopsoas to the GT, and that is still experimental, and the results are very encouraging. As Mr. Dhar mentioned, we have got 4 goals. First is to have a good metaphyseal fit. This was quite useful when you used to do cemented stems where they used to fill up. We used to definitely keep a gap. Now comes someone tell me why this has failed 3 times. This is the 3rd X-ray we are looking at. Anybody? What has happened above? Why the stem is looking like that, broken and shifted like that? So this is a Dor type 3 champagne flute stem. And although there is a distal fixation, but the proximal metaphysis fixation was not there. So it kept on having a viper type of effect, and it has failed the 3rd time. So it is very imperative that we understand what is the fail, what is the fit. Another thing is the neutral axis, but sometimes you might have to increase the antiversion more just to increase the stability within the parameter. Again, there is a Dor angle into that also. Restoring the neck length and the offset is the most important. So this is the vertical offset which we talked about. And these are the parameters for preoperative templating. Selecting cup size 4 to 6 mm larger. Inferior margin of the level should be teardrop. And use an acetabular shell template to mark the femoral head center using the template tool as a guide. Now these are the templating where the concentric circle of the femoral head and acetabulum should generally coincide. And this is what again the templating is all about. Now Mr. Dhar talked about these extended offsets. Our teaching understanding was, if you increase the offset, you will increase the advantage of the mechanical arm, lever arm that is. But this is within the limited frame, because you see there is not a huge difference in the offset between the high offset like KL stem and the normal stem. But if for some reason you increase the femoral offset too much, that will again cause micromotion at the bone implant interface, and that might also cause pain. Similarly, if you can increase the acetabular offset, then the strain will be more on the acetabular side, and there might be pain in the acetabular side also. Sometimes things don't go plan as we have done it, and this is one case operated 20 years back, septic arthritis. There was an anterior scar, lateral scar, multiple adhesions, flexed flexion deformities, multiple bones being chipped off from the shelf. We opened up. Luckily, there was no infection, so we decided to go for it. But the X-ray was not what I was expecting to see. So let's show you my Hall of Fame. So somebody was just now asking me about the acetabulum offset. Now, what type of stem is this? Gentlemen? Who's that gentleman who was just asking a question about offset? What type of offset is this? High-end offset. And what is the neck shaft angle in this offset? What type of hip is this if you compare on the other contralateral side? Is it a valgus hip or a varus hip? How you define a valgus or a varus hip? Okay, so where it is coming to? It's a valgus, and if it is at the level, it is normal, above it is. So basically, this is a varus stem which you have done it. It's a collet prosthesis. So as Mr. Dhar was just before telling me, you have to modulate your plan according to the neck. So if you are expecting a varus neck, you should have a varus stem ready. I generally use Johnson & Johnson for THR, and their only collet prosthesis is available. So what will you do in a varus neck? Will you take a lower cut or a higher cut? See, here there is a very low cut, isn't it? Of course, it was a struggle all the way throughout. So generally, you in varus neck, you will have to take a lower cut. In that case, you might not be able to justify a collet prosthesis. You understand? But you don't have much option. Nowadays, the cemented one, they are okay with this type of placement. Before, they would always insist on a valgus placement, especially in the cemented one. But the uncemented one, the recent literature is saying that they are very forgiving with even a central placement of the stem. Otherwise, cemented stem, they have to just go touching the medial side of the cortex. That was our classical teaching. What about this acetabular offset? Do you think it has increased or decreased? Increase. So how that is going to manifest? Well, not necessarily, because this is within moderation. And does the horizontal offset changes the length of the leg? Tension of the muscles. So you will struggle that the gluteus medius has become very taut. You will struggle in attaching the external rotators if you are going by posterior approach over there. What else you are having expecting problems? Okay, we'll discuss later in the meeting. Any fine. How do you measure the limb length? Is the limb length equal on both the sides? Well, stem is not proud. The cut is very narrow. And if you compare the head, yeah, it is, this is, in spite of being in the varus stem, this is the state of affairs. What will happen if you try to put a normal stem in a very varus hip? This hip is not too bad. Sometime a real varus, what will happen? Okay, we'll discuss in the next. So now spinopelvic alignment. Nowadays we are getting hip spine disease and spine hip disease. And again, how you measure spinopelvic dimensions are different. Orthopedic surgeon will always measure in a very classical manner, but they will measure from anterior superior iliac spine and in the front to the sacral promontory and then to the symphysis pubis. So when you are sitting, as Mr. Dhar has mentioned, there is a backward tilt of the pelvis, decrease in the lumbar lordosis and anteversion of the cup. Except in the flat back syndrome, when there was a suggestion that there might be retrovirus, sometimes it will cause more anteversion and you might end up conversely increasing the anteversion of the stem. In this case, the only solution is take sitting x-rays and maybe you can do a CT or dynamic CT if your conditions permit. So that is how the position is. Now this is very important, although not so like you're doing Van Langenbeck's approach where you want to preserve the arteries. You reflect it and pull it back and do circumferential exposure of the acetabulum rim and protect it for the lateral repair and use the pin retractors. So again, I am borrowing the same slides. I generally put the ischial spin, 2 on the tal and the retractor, anterofemoral retractor on the superior part. Otherwise, if you get femoral neuropraxia, it is not a good thing. Then again, your pelvis should be stable. Ilioischial plane is the best plane, but that is not my favored one. My favorite one is the tal, assuming it is not calcified or absent. Sometimes you have to take consideration of that also. You can put a scale from the upper part to the Chanley spin and compare it to the trochanteric region before you dislocate the hip. That is also one thing in which you can measure the length if you are worried about the offsets and the limb length. Now taking the horizontal offsets and measuring vertical and horizontal offsets, and then do the neck osteotomy. We just discussed the neck osteotomy. In the varus, you will go lower. In the valgus, you will go higher. Always are on the safer side. Always keep the neck. Make sure the saddle, where the greater trochanter attaches with the neck, you go slightly below it. Otherwise, there will be notching. And then rasp and lateralize. Because that way, you will not have the tip pointing to the lateral surface. The most common perforations are lateral and posterior. So what you do is, you keep on sliding the tip medial side, although as I said, in the uncemented one, that is not a requirement nowadays. Even the central position is reasonably acceptable. So that is how you have measured the horizontal and the vertical offsets. Then again, that is a saw, but I just use one finger bed that is 2.2 centimeter above the lesser trochanter. That is a saddle over there, and you take the measurements. And as Mr. Dhar mentioned, you have a 360-degree exposure. And then you apply properly the two. I generally don't have etc. type 1 and type 2 retractor, but you need to put two retractors below the tal. One, I generally put one channel pin in the ischia, one above, and then the anti-femoral retractor. Take number 44 reamer, rim the base, so that all that ligament teres and all is taken care of. And then the outer part, like the U-shaped part, you just obliterate that margin. And then you gradually increase the size of the reamer, and then you come towards the peripheral side. Nowadays, those who are doing by robot, they will realize there is only one reamer, and the robot will go with just one wheel, and then they will next they will put on a cup. So, acetabulum preparation is the key, more so in the dysplastic hip. And in the hips where there is a bone loss, don't eccentrically ream the acetabulum, otherwise the posterior wall will become very thin. So always hold it with the hand of a pinch and see you are not doing eccentric reaming. Cup orientation, classically we will tell 45, then it became 40, and now I am keeping my cups on 35 degrees. Because if you look and go into the literature, even 35 degrees could be the 40 degrees. So you don't want your cup being more vertical. Does that make any sense? Because horizontal cup, like a Mexican hat, will always give you more stability. So that is the anti-version. Yeah, retroversion of the neck. If God forbid that happens, then you are in disaster because your hip will start dislocating on the table. Anti-version, at least it will dislocate after few weeks or maybe within the first 3 weeks. But if your retroversion of the neck, it will start, you won't be able to just put the hip back over there. Again, rasping is very important. You lateralize the rasp. You make a box cut chisel, lateralize it so that you don't perforate the lateral cortex or the posterior cortex. Always check for the micromotion and go for one size up. Always pay due attention when the sound impact changes. You can have various offsets while you're doing the dislocation of the hip. You can go high offset, low offset neck, plus, minus, and neutral size head to get the best fit over there. Avoid subsidence at all cost. Breast, feet, and feel are very important. 32 is the best. We have done 44 also before in 2005 ceramic heads, and we thought the bigger the better. But I think 32 one having this stood the test of time. So this is how you check it and how you reduce it. Now impingement mostly occurs at 5 o'clock over here and 7 o'clock position. Nowadays you seldom see this skirted type of the heads, but it could be bony impingement and soft tissue impingement. If it's a bony impingement, we are okay. We can just take a small osteotome and chisel off the part of the bony prominence above the cup. Soft tissue impingement, you have to do extensive anterior release if you are going by the posterior approach. Suppose if this is the anterior margin, you have to use the cautery to release all over here. And conversely, I have done quite a few by anterior approach and the modified Harding's approach also. That is the way I started. In that case, you will release the posterior if there is a severe fixed flexion deformity. So that is a very important thing, as I was told. Reduction, we all know it, no excessive force, no rotation. Otherwise, in geriatric population, we are all going to uncemented more and more with each passing year, your real risk of fracture. Combined angle of anteversion, that is collinearity, your cup, head and neck should be in one line. And classically, it has been described as around 40 degrees, 30 to 40 degrees. But sometimes I have found in revision, very severe contracted, I was very happy, but when I tried to take this angle, combined angle of anteversion, it was barely going to 15 or 20 degrees. Maybe it was a contraction, maybe that was not the ideal condition, I really don't know. But this is a classical textbook teaching of the combined angle of anteversion. This means it is combining the anteversion of the cup as well as of the neck. What is the difference between anteversion and anterior torsion of the femur? Can somebody tell me? Where do you look for anteversion and where is the anterior torsion of the femur? Maybe you like to take a CT scan, start from the sacroiliac joint to tibial tuberosity and then look closely and then you will realize, I'm sure you know it, what is anteversion and what is anterior torsion and how it is related and how it makes a significant difference to our understanding of the femur. It is not the anterior bowing or just the 15 degrees or 20 degrees of anteversion in males and females respectively. So dual mobility, either you vouch for it or people like me have seldom used dual mobility. They are not without their problem, they are not the one-stop solution. Can you see? There is a dislocated liner over there, very common, although very rare with the dual mobility. I have seldom used dual mobility. I'm a very slow surgeon. I will change the anteversion slightly, make the cup close. Sometimes I'll use the lip liner also, although it is not indicated. And it is very difficult to reduce the hip. When it is very difficult to reduce the hip, it is very difficult to dislocate as well. Remember that simple dictum. Constraint liners, they look very fancy, but God forbid, they do dislocate and they routinely dislocate. And the funniest part is that once they dislocate, you have to go for open reduction. So that's a nightmare. And God forbid if some intrepid registrar tried to open it up and tried to reduce it again, then it is very difficult to dislocate it again. So constraint liner, I don't think there is much role unless and until, but if they dislocate, then you have to go for open reduction. You have to keep that in mind. Highest center, after DDH, our understanding has changed substantially and highest center of rotation is perfectly acceptable. Although these augments are very good, but if you are cementing them, their longevity is not as would of an uncemented construct which you are used. Maybe a cadaveric bone graft and fixing it with it and try to fix it. So augments are very good, but the moment you use the cement, unless until it is inevitable, their longevity tends to decrease. Now, we have all thought that the lateral approaches, there is a limp because of the superior gluteal nerve. Posterior approach, there is a risk of dislocation. But you repair nicely the external rotators and the capsule, the dislocation rate is reduced by 31%, and then it approaches almost as good as direct anterior approach to the hip, which nowadays is being touted as the best approach to do the primary hips. I don't know about doing secondaries with that. So you all know, drill the 4 holes, repair the capsule, and always gluteus maximus you can make a snip and then reattach it. Otherwise, if the lady patient or even a male, they will complain that there is one buttock is sagging and one is perfect. And you just attach the piriformis and the short external rotators and fix it to the GT with the help of needles or whichever way you prefer. So what exactly we are achieving for? Securing bone support and cup inclination. Even 20% exposed cup is okay. In universal jumbo cups, you can have even 60%, but they are very big cups, very large surface area. Anteversion 40-45 is a classical, so stick to that. Many people, I have now gone to 35 degrees on the primary X-ray. Anteversion of the stem and restoration of the hip center and offset. You can't go much wrong with the offset. Even if you use a high offset, it is not like you're increasing by 20 millimeters. They are within the normal parameters. Only thing is that gluteus medius might be taut and the posterior capsule repair might be a bit arduous. You will struggle with that. And of course, the restoration of the limb length, which Mr. Dhar has discussed in great detail with you. That's all from my side. Thank you.
Any questions from the audience?
Yes. So good evening, everyone. Thank you, BOS, for this opportunity. It's the last lecture. So I've been allotted choosing right femoral stem, principles, pitfall, and preferences. For choosing ideal femoral stem, you must all know about proximal. What is proximal femur loading? What is the load sharing? What is the fixation mechanism of this cemented and uncemented? And femoral canal anatomy, what is the shape, offset, and anteversion already prescribed by Dr. Dhar and Dr. Paude. So load sharing, now all of you are young and you must know what is load sharing. As you know, the load is transferred from femoral height to the implant and then it goes down to femur bone. For survival of a stem, whether cemented or uncemented, the load sharing should be uniform between implant and bone. And the fixation between implant and bone should be very stable. And they should be minimal, there should be reduced, we should try to reduce negative impact of elastic modulus difference between bone and metal. Because bone is soft and metal is very hard. Now what is the elastic modulus difference? If you see here, cortical bone elastic modulus is 16 gigapascal. And if you see the spongy bone is just 0.1. Stainless steel implant we use, then the elastic modulus is 200, titanium 110, cobalt chrome 230, and Parma or bone cement 2.2. So there is a huge difference of elastic modulus. So it acts like a hard spring inside a soft spring. So what happens when loading is happen? So there is always tendency of maximum load to transfer through metal distally directly bypassing the proximal femur. There's a tendency, and all the implant design, they try to minimize it. They want to redistribute this force. So now this elastic modulus difference depends on type of metal, as I told you. Size of the implant, bigger the implant, larger is the difference between bone and metal elastic modulus. And cement mantle, if you are using cemented, then the mantle should be uniform and as per the manufacturer. So this disparity of the elastic modulus to understand and to minimize by any cemented or uncemented is just to understand basic is very important. Now what happens if there is an asymmetrical loading? When asymmetrical loading happen as a Wolff law, you must all be knowing, the asymmetrical load distribution result in absorption of the unloaded bone and hypertrophy of the overloaded bone. This is called stress shielding. And due to stress shielding, whether it is cemented or uncemented, the loosening happens and thigh pain happens. So this causes stem loosening. And this we have to avoid by which I'll describe later on. So you must understand all these basic principles. Now, cemented and uncemented fixation philosophy. In cemented, fixation is achieved by cement micro interlocking with bone and uniform stress distribution to reduce elastic modulus. In uncemented, the fixation is by geometry shape, osseointegration, and then stress distribution as per biomechanics. Now, cemented femoral stem, the biomechanical principles are implant shape, position it should be center, the cementing technique, there should be good micro interlocking, and cement mantle, which is very important to reduce the elastic modulus between hard, very high elastic modulus of metal and low in this. So it has a cement mantle as a buffer. Whenever cemented stem is used, the broaching is very important. We have to do the exact broaching, because when you do the exact broaching, you get the exact shape of the bone bed and adequate as per the size, and then you get proper mantle, cement mantle, because broaching, they are different with different stem design. Charnley's, Exeter, and C-stem, they have different mantle. Like every implant has specific cement thickness which is required as per their biomechanics, and we have to respect that. Do not do like whatever the broaching should be perfect. When you do the broaching, it should sit properly, not like the implant person says, sir, ye thoda tight hai, ek size chota dal do. In that way, what will happen? Your cement mantle will be very thin, and eventually it will lose. So cement mantle also, if you read any company manual, it is mentioned there cement mantle is 2 to 4 millimeter, or if you are using like French paradox, like Corel, is just 1 millimeter. So we have to go as per the company specification and guidelines. Now, for good cementing in a cemented stem, you must know the modern cementing technique, which you have to use a pulse lavage, intramedullary restrictor, and proximal pressurization. These are the mandatory. Without that, good cementing is not possible. Now, after cementing, if you know you must know what is Barrack's type A. The Barrack's, Barrack has classified the cementing in A, B, C, and D category. And in cementing zone, there are 12 zones, 7 in AP and 7 in lateral. They are called Gruen zones. So in that, all the zones, they should be white out. There should not be any radiolucent line between cement and prosthesis. If you appreciate here that type 1 is white and white, then no, you can't see osteolysis. B, you are saying randomly some osteolysis is not a good cementing. And C, if you see, there's a lot of osteolysis line. So it's a type C cementing. So always aim for a type A cementing, and that the survival is maximum. Now, the cemented stem, if you see just for knowledge, they are classified in 4 or 5 types. But you don't have to go in detail, but you have to go on how much mantle is required for that. And if you see long-term, all this stem, if you followed the good cementing technique, the long-term survival up to 20 years is excellent. So broaching, cement mantle as per design recommendation is critical if you are doing a cemented stem. Now cemented stem, gradually we are losing it for several years. Now uncemented is more popular. The reason is because the gradual loss of experience, training centers, and there's a trend effect of using uncemented, marketing promotions, and overhype of bone cement implantation syndrome. In that, what happened is called BCIS. There's an immobilization happen when you use a cemented stem. But it is overhyped. If you see the randomized control trial, they found no difference between cemented and uncemented BCS bone cement syndrome. Now coming to uncemented stem, there are 3 fundamental principles. Initially, rigid stability as per the size and shape. Mid-term, there is the osteointegration between the implant and the bone. And then balanced femoral stress distribution for long-term survival. Based on this, there are 40 or more than that kind of stems. Only thing which is important to you, you should always know, there are only 2 types of stem. One is called ABC, is flat tapper, quadrangular, or fit and fill. Now these stems, they always fit here in metaphyseal and metaphyseal diaphyseal junction and 3-point fixation. This is all majority of the stem. And then the load sharing happens in this metaphyseal diaphyseal junction. Distal part is always free. The tip is always free. And conical or cylindrical, they fit in diaphyseal, which we use when there is a proximal deficiency like revision or Wagner stem. So these we use in revision or trochanteric fracture. Now if you use a stem which is fitting here and this part is loose, then as I told you, there will be stress shielding and eventually thigh pain and loosening. Uncemented, they are most popular, 96%, and trend is multifactorial as I told you, but none of the uncemented stem is free of thigh pain or stress shielding. The reason is this technical, because we frequently use various stems and then we don't implant them properly. One of the complications which has happened recently for last 5 years with uncemented stem is periprosthetic fracture, especially because most of the uncemented stem we are using tapper, and when a person fell, the tapper it sinks in and it's called X effect, the taper split the femur and causes this Vancouver type B periprosthetic fracture. Now, because of this, now there's an uncemented, all the companies, they have come uncemented stem with a collard. Because of collard, this X effect, when person falls, the stress goes through this calcar, and the X effect of taper is minimized, and they get less periprosthetic fracture. So if you see the trend, current trend is all the uncemented taper stem, they are coming with collar. Now, this is most important. All of you should do a X-ray with femur minimal up to at least 150 millimeter or 10 centimeter from LT. And on that basis, you classified door A, B, C, the ratio between at the level of LT and at the diaphysis. Now, if this, all of you must be knowing, if you don't know, you should always do door classification before you decide for doing a THR. And it is your anatomy of the femur that decide whether you are going for a cemented or uncemented, not other way around. So always do the proper X-ray. Now, it's interesting to know as the person get older, this, for example, this type A and also in osteoporosis can become type C when due to osteoporosis, and if someone at 40 years become at 80 years. So this cortical thinning happens with loss of bone with age. Now, door A or a champagne fluid is very high rate of complication after THR using uncemented taper wedge stem than type B. More radiolucent line around femoral stem. The reason is revision, and there are more chances of periprosthetic fracture. Now, door A is always problematic. It's called also champagne fluid like this. Now, what happens when we do the uncemented? The stem of this uncemented get catch here. It's called diaphyseal catch, and proximally there is no loading here. So the entire load, as I told you, goes through the tip near here, which should be a free, and there is no metaphyseal diaphyseal load sharing. So what happens? There will be stress shielding and also thigh pain and fracture. Now, if you see intraop, when you put your brooch, the brooch get caught distally and it moves proximally. It's called diaphyseal catch. This is very, very typical for the door A, both in cemented and uncemented. And solution for this is you do, if possible, do more reaming, make the distal canal free, and then you can use a thicker stem which can fit properly. But sometime like this is, for example, it's a door A. In this you can't make it because the X-ray is very short. You have to do a big X-ray, a long X-ray, and it's type door A severe. And in this case, the ideal is doing a young patient, doing a hybrid uncemented socket and a cemented stem. So door A, if you either you try to ream it and make it for uncemented, if not possible, go for cemented. This is after 3 months. Now door B is very simple. You can do uncemented. It's ideal for uncemented. You can do cemented also. And door B, all the implant design, they fit well. Door C also, if you see, the canal also called hosepipe canal. These are ideal for cemented. If you use uncemented, there is a high rate of complication because the implant size gets bigger. There is a more elastic modulus difference, and there is more stress shielding. As I told you, type C is also a sign of a poor BMD, poor bone mineral density, and there are more chances of periprosthetic fracture. Cemented, less complication. Also, in a cemented stem, the diameter of cement, the stem is very, very thin, and the cement mantle is more. That reduces the elastic modulus, and there's less stress shielding and less periprosthetic fracture. For door C, always go for cemented, and in some cases, very high risk patient or elderly patient, you can go for a collared stem, but not for a regular tapered stem. This is a young patient, 30 years, but types C, door, and then I have to use a cemented stem. Now, offset already, it's been discussed by Dr. Dhar. See, you should always measure normal side global offset, femoral offset, and acetabular offset. Okay, global offset is femoral offset plus acetabular offset. Pre and post, the global offset never changes, it remains same. However, due to medialization or changing by reaming, acetabular offset can reduce, and the femoral offset always preferred to increase. At the end of the surgery, there should be plus minus 5 millimeter of global offset. There should not be, if you increase the offset, the global offset, then there'll be more tightness of gluteus and excessive acetabular pain. They get a lot of pain also. So end of the, you try to do major pre-operative and post-operative. As I explained by Dr. Dhar, the offset changes with femoral neck shaft angle. Coxa valga has low offset. Coxa vara has more offset. Now, if you are using uncemented femur, the uncemented femur, the anteversion is decided by anatomy, and it varies from 0 degree to 15, 16 degree. In some time, when the anteversion is more excessive, especially in DDH, then you cannot use a regular uncemented. You have to use a conical type of Wagner type of stem or a cemented stem. So this is when you want to adjust anteversion, you can only do by either a conical stem or cemented stem. If you go by registry data of all the countries, now protocol is, if patient is less than 75 years, you go for cementless. If patient is more than 75 male, you go for hybrid, that is cemented stem and uncemented cup. If females more than 70 years, then you go for a uncemented socket and cemented stem. Now take home message, surgeon must know technical detail of implant design. Accordingly, meticulous canal preparation, broaching is very important. Cemented stem, thickness and quality of cement mantle is very important. Uncemented stem, fixation as per the geometry. Most of the time, we use the taper stem, so proximal fixation is important. Distally, the implant tip should be free. Proximal femoral anatomy is very, very critical. You should choose the implant as per the proximal anatomy, not the you should order implant and go for any femur. So door A, avoid diaphyseal trap in uncemented, and inadequate cement mantle if you are using cemented. Door A is always problematic for both the stems. Door B ideal for uncemented. Door C is ideal for cemented. Or if you are using uncemented, you should use a collar. Balancing offset is critical for abductor function. Reducing the acetabular minus 5 millimeter, increasing femoral plus 5 to match the global offset is never 5 millimeter here and there, but the global offset should be same pre and post-op. Periprosthetic fracture, especially type B Vancouver, they are less in collared uncemented stem and also in cemented stem. So periprosthetic fracture, because of that, the collared uncemented stem is now preferred. Above 70 male and 70 female, cemented stem is preferred all over the world. There is no difference in long-term outcome of cemented or uncemented femoral stem in literature. Thank you. Any question, please let me know.
Thank you, Siddharth sir.
Yes.
So we will just take a 5 minutes break. Just grab the snack. If there is no tea, then we will bring it inside. I will just bring it inside. Just take a 5 minutes break and then come back again for the breakout session.
What they do is, there is a discogs also, that canal and this diameter. But see, at isthmus it looks pretty alright. There is regional osteopenia at the top. Okay. So patient position, implant selection, uncemented, cemented. Uncertain. You have seen the X-ray, that's why?
No, sir,
Type B. So, how is the cup medialized? Well, it is touching the teardrop. Okay. Limb length is okay. So much internotation, I am struggling to see the tip of the LT. So, by and large, okay. Only thing is that the stem could have been more lateralized. See, there is a lucency at the top. And I think it is fully coated stem. So, that's not bad in this case. Okay?
So we have to increase the size of the stem.
Yes, one size up, and what I think is that, see, when you make a cut, see, the way I do it is, we make a one finger bed, and you go from here up to here. This is the saddle. If you look from the front, this is called as the saddle. So, generally we posterior approach, all by posterior approach. Good. So, one finger bed, that is 1.2 centimeter, and I mark with a cautery, or you can take that and you can put it on that mark also, that all this, and make a cut like this, and then use an osteotome to make a vertical cut. Don't go like this. Go like this and just stop short over here, and then put a one vertical osteotome. Then you take a rat tail rasp, lateralizing rasp, small rasp, and you keep on making it, because what happens here, there is a ridge over here. So you take a rasp and point it towards the medial cortex and keep on rasping it. Otherwise, what happens, you see, that stem and the rasp is going vertically down. And what you do is, you try to bend the arm towards the inner side, towards the hip side. So you can see there is a radiolucency over the top. So he has not used the lateralizing rasp, and the direction of the rasp should be like this towards the medial cortex. Because the common perforations are very osteoporotic 90-year-old ladies on the lateral side and on the posterior side. So you point anteriorly and medially. And it should go like this, not like this. That's it. See, ideally we don't need screw. Some people will say through screw, some people will say one screw, because from that the stem cell comes out just like microfracture goes. Each one is having their own ideas. Okay? Whichever you fancy, that is perfectly fine. I have heard so many things that I have lost faith in myself in all the conferences. I generally don't put screw, but if there is a hole there, it makes sense to put on that screw. But one screw alone can't control any macromotion. It has to be 2 or 3, to be honest. 3 is very ideal. Okay? Good. Now, operative steps, post-operative X-ray analysis. So, operative steps, there is no point in discussing. We will discuss at great length. Now, read out, young man, from your side, what is this? So, why anything rings bell? 36 is a young or old? Okay, rheumatoid arthritis. So what picture comes to your mind the moment said 36-year-old lady, rheumatoid arthritis? So what are you looking about in her image?
Degenerative changes will be.
What else? Is it like osteoarthritis? Osteoporosis, very good. Bilateral TK done at the age of 31, right? Non-ambulatory since 1 year. So it is going to be very mushy bone. Lot of pannus. When you open up, you start wondering whether it is an infective hip or what. If you open up the arthritis, this badly rheumatoid hip, it's a nightmare. You honestly start believing that there is some infection in the hip. Okay, now what is happening? So why protrusion? Enlighten me. Why protrusion? What is the definition? No. What is the definition of protrusion?
It is crossing the ilioischial line.
Okay. So where is the ilioischial line? Show me. Thank you. Yeah. So it starts. See, there is a nice specimen over here. So the ilioischial line is. This is very big things. So it starts inferior to the teardrop and goes from the greater sciatic notch. Yeah, greater sciatic notch. This is not a true fatigue. It starts from greater sciatic notch and to the teardrop. And the teardrop is the inferior and the middle part and maybe the superior part of the obturator. You are agreeing with me? This is, I hope I don't rupture this. नहीं ये बिल्कुल ही गोल है. इसमें कैसा किडनी जैसा रहता है. So it is on the top of this and the most inferior and the posterior part of the acetabulum. So It has crossed that. So the moment I say protrusion, and what other things are happening? Where is the grota trochanter? Migrated, proximal, there is a proximal migration. And the head is all completely destroyed. There is a severe regional osteoporosis. If your assistants are very proactive and they think they can pull everything, you are in a big disaster. You need to have trochanteric plate, DCP plate, everything with this. Now, what else? Yeah, but that you will manage. वो सब मशी बोन रहता है, ऐसा करोना तो बिल्कुल हाथ से भी निकाल सकते हो आप, many times. Now, what other things you are looking for? What are the problems with protrusion acetabular? Is dislocation of the hip very easy? See, here you will just make a cut and you will start looking at the hip. But if it is into protrusion, what you are going to do? Your acetabulum is almost up to here. First thing is how to approach it. So many times there is a dual approach also. So you go posteriorly approach like this, just keep it slow, and then you go by the modified Harding's approach. Otherwise, people have even cut acetabulum while trying to make blindly the saw. You understand? So this is very important. You understand the dual approach. Sometimes you have to just leave a sliver of trochanter. You make an anterior cut like this. You know modified Harding's approach. You put in the lateral position. You make a 2 centimeter incision above 3 centimeter is the superior gluteal artery. If it bleeds profusely, you are going to get a limp for the rest of the life. And then you make omega shaped cut over here. Then you come over here, you put a bone spike and you see the femur. So you, in the lateral position, you go both the posterior approach and anterior approach, modified Harding's approach. Put the bone spike and then make properly and then make a proper cut. Otherwise, you will end up cutting the acetabulum.
Where we put the bone spike from the anterior side?
Just over here. See, lateral approach, no? You make a small cut, omega shaped incision over here. And the first thing you do is you put a bone spike and do it like this. Right, lever it out. And then make a cut all gradually around here. And that's fine. And just keep a trochanter attached to the piece of muscle. It is very tight. It is not as easy as it appears. And you take almost 40 minutes just to do the osteotomy. But I'm very slow surgeon. I'm perfectly okay with that.
The omega shape, the sleeve that we raise is, so we...
No, you first see, first you do like this and you make a 2 centimeter cut in the gluteus medius. And then you make an omega shaped incision over here. The moment you use a quatrain, just little bit of it is exposed. You just put a bone spike and turn it around all the I done capsular muscle all in one go. So you get a nice neck over this side, a little neck. Maybe you will see only this much of neck over here. You don't want to randomly cut and come out somewhere over here. So that the whole of the anterior wall of the acetone, this has happened to many people. Okay, what next? Dislocation is very difficult, osteotomy is very difficult. You might need a dual approach. Then, sorry?
The gluteal trochanter is medialized.
Yeah, so most of the reason otherwise gluteus medius is contracted. The way it is ankylosed, almost ankylosed, right? What else?
The landmarks have disappeared like tal and all these things. Very difficult
Tal
to
will
look
be
at.
there. In this case, see, even teardrop you can see, at least on the X-ray.
Bones are highly osteoporotic.
No. Medialization. So how you are going to prevent medialization? You have to order cadaveric bone, multiple cadaveric bone, and you have to pack it, okay? And then you take a big cup. I would, if conditions afford, you can go for a gription cup. So you just trim it, don't do too much, and just fix it. Gription cup has very good strength. You don't need to do like coral pinnacle. Just hammer it. The whole thing will collapse and fall down into the pelvis. Okay? And then you start with the femur and the natural way.
So do we have to ring?
Of course. The gold standard will, because that will be sclerotic. Ideally not to go to the cancerous mushy bone. Just Mr. Dhar was saying, just it starts punctate bleeding. That is the best thing. Identify the tal. Just in this case, just pack the bone graft, rim peripherally, bone graft, and you know that cement pressure before when used to do cemented, anything like head pusher or something, gently, okay? And peripheral fit, a gription cup is good enough. It's a very costly cup. You can even get along with the coral cup also. I don't like cemented one nowadays, and you go ahead with that.
We don't have to go any medial rim.
In fact, there is nothing to rim medial. You have to pack bone. Okay, so you have to order cadaveric bone graft. This head and neck, I don't know what is the quality of the bone, whether it will be useful to put it there. So always get 2-3 heads. not some 2-3 small packets of bone which are good for nothing. You will need massive grafting into that. Let's see the post-op X-ray.
So it's going to be cemented or uncemented?
Uncemented, please.
Uncemented.
Yeah, basically I am going into more into uncemented one, but I won't mind rheumatoid somebody goes for cemented also. So approach, patient position lateral. Okay. Okay, so they discuss high riding, arthritic hip, head resorption, and grade 3 protrusio. So we have discussed protrusio. The moment you say protrusio, you know the high riding. Difficult to make an osteotomy, difficult to do reduction. We need to keep a bone graft. Depending on rheumatoid, whether I will do uncemented, but I won't fail anybody if somebody says he is doing cemented. These things should automatically one by one come to your mind. Again, on the top of that, osteopenia, very weak bones, some TKR, maybe some supracondylar fracture, she is lying on the bed. It's a disaster. Some rheumatoid arthritis, guy giving steroid everywhere and anywhere. Yes, hello? Yes? अभिजीत सर को बुला लो ना प्लीज. एक मिनट. क्या हो गया? हाँ, अभिजीत सर आ रहे हैं क्या?
अभिजीत सर है यहाँ पे, लेकिन पेशेंट का रिलेटिव है, उनसे आपको ही मिलना है.
ठीक है, तो उनको बोलो मैं जरा 45 मिनट्स में आ रहा हूँ, 30 मिनट्स में आ रहा हूँ, है ना? 20. आई एम इन द कॉन्फ्रेंस डाउनस्टेयर. थैंक यू. Okay, so they have done a cemented one. Okay, and there is a cemented stem into that, and cup also.
Cemented inferior to the teardrop.
क्या हो गया?
The cup is that is inferior to the teardrop.
हाँ, तो इससे कोई बहुत फर्क नहीं पड़ता. दिस लेडी वॉज बेड बाउंड. अभी मैंने भी एक एक्सरे बताया था ना, जिसमें पूरा सेप्टिक था, ये था, उसमें मीडियल बहुत था, और अगेन इट डिपेंड्स ऑन द ओरिएंटेशन ऑफ द एक्सरे ऑल्सो. दिस एक्सरे लुक्स मोर एंटीवर्टेड, है ना? ऐसा लग रहा है हिप फ्लेक्शन डिफॉर्मिटी होगा, या पता नहीं कैसा है. इट इज मोर एंटीवर्टेड दिस एक्सरे. इट इज इन द फ्लेक्शन, है ना? So this is not a true X-ray, but I agree with you. It is slightly inferior, but it is well covered with the bone. थोड़ा सा क्या?
Too much calcar.
नहीं, वो उसमें we don't get space to enter. आप रीम कैसे करोगे? Like I showed you my X-ray also, if you remember, I have to cut neck up to the LT level. है तो शुरू में बड़ा टेंशन हो जाता है कि आप LT से कैसे नेक काट दो. But later on, when you do many cases, I'm basically a revision surgeon and a young adult hip surgeon, then you become accustomed to it. It is not always textbook. Even मेरे को तो combined angle of anteversion revision में दिखता ही नहीं है 15-20 से ऊपर. Even if I bend the knee, that you should not go with this idea. You are here for a basic course and you should go with the basic fundamentals, right? So don't worry much about that. If it serves the purpose, if she is pain-free, she is able to walk on it, we have achieved our nirvana. Don't go for a textbook picture.
Mild shortening.
Yeah. क्योंकि I told you ना, उन्होंने शायद trochanter भी उड़ा दिया है. I think the trochanter has also gone missing. है ना?
थोड़ा सा पार्ट दिख रहा है.
हाँ, वो नहीं है, वो उड़ा दिया है उन्होंने पूरा ऑस्टेटोमी करने में. होता क्या है, you can only go up to 2 to 4 centimeter. More than that, you will get sciatic nerve palsy. That is a very bad thing.
Sir, cup position ऐसे में क्या करना है? Close to trochanter is not fixed again.
या ट्रोकेंटर को पहले हम लोग ट्रोकेंट्रिक ऑस्टेटोमी करते थे विद द लैटरल अप्रोच टू द हिप, एंड 80% ऑफ द टाइम दैट वेरी इंट्रिकेट चैनल्स, सर जॉन चैनल्स वायरिंग, इट नेवर यूनाइटेड. 20 to 30% united, but that was by the hand of God, not by our wiring of the trochanter. That wiring will not go away. It was like a tension band, 2-3 circles and very intricate. So the trochanter is missing. But see, what was the treatment of the arthritis? It was a floating hip. If you look into anthology of orthopedics, the first treatment described for arthritis of the hip was floating hip. They used to cut off all the abductors, all the tendons. You will be surprised, and the pain used to go away, because what happens, all the muscles pull it. So even if the trochanter is missing, so you remember the first operation for the hip was, for arthritis was, they would cut off iliopsoas, gluteus medius, gluteus maximus, everything, so that the pressure, intra-articular pressure will become less, and then they will attach to somewhere rather than here, over here, and they will start working again. So don't worry about that. It is not ideal, I know, but you must not go with an idea that something bad I have done. Okay, so maybe the trochanter has gone, but in this case, as I was discussing, you might even inadvertently use the saw, you don't get place to get in, you might even just cut the anterior column also. Okay, are we clear on this? Okay, next now.
So once again, can you please explain about the approach used here?
Yeah, ideally it should be the posterior approach, but as you can imagine, see, the trochanter is riding quite high, just like this. Okay, so ideally I would go with a posterior approach. Within mind, I might need a dual approach. So posterior approach you do, but you don't file anything. You just see head and acetabulum up to here. So how you are going to do it now? You have done a nice, maybe you are able to see some lesser trochanter up to here, and this is all acetabulum, exactly like this. So then you make a small cut over here, make a wind on over here, go over here, try doing something like this, get some space, and just cut the neck. So that is a dual approach. Sometimes complete denuding has to be done. Okay, in that also, so it's not an easy case. So the whole idea is you shouldn't fumble. You are doing 10, 20 hips very well and you start thinking, I am the hip surgeon. And then you get 2, 3 cases like that. One, God forbid, one gets infected, one starts dislocating, and one you struggle for 4 hours. And suddenly your confidence comes crashing down. So this type of things do happen in early stages. Okay. Anything else you want to ask? We have been asked to finish quickly. Now again, 59 years old. What does that mean? Pain in the left eye, inability to bear weight. What does this mean? Fracture, arthritis, any oncology, any tuberculosis. What is a big selection in orthopedics? TB, tumor, fracture, and arthritis. Is there anything more to it? I think 99% cases will come in one format or another in these 4 conditions, right? This was the way our registrar is to teach us for the exam. So, bipolar hemisphere was done in 2018 for fracture neck of femur. Now it has become crystal clear. What is the cause of pain now? Yeah, it is an uncemented one, lateral thigh pain, because it keeps on jolting like that. It might go in. Loosening of the ankle. Yeah, so hemi, that is my previous.
Suppose protrusio acetabuli is there, then protrusio acetabuli you can make, like there is a more medialization in protrusia. So how do you treat protrusia? What do you do intraoperatively?
Bone.
You can put a bone. Then what else? Acetabular cage and all, see, these are all for different type. Simple as protrusia is there. You can use a bone cage. Okay. You can use acetabulum. You can use a bone graft, and you can use a mesh, titanium mesh. Put a layer of bone graft, morcellized bone graft, then put a mesh on top of it, then put a trial, then again on mesh you can put a bone graft. So that mesh prevents the medial migration of that. That is one of the way. Or you can take some big pieces of bone and you can put there, and then you can put a trial cup there, and then in addition to those big pieces you can put morcellized bone graft, what you get from the acetabular rimming, and then you put a trial. If you have doubt, automatically your femoral acetabular cup will come anteriorly or laterally once you put those support there. Sometimes we used to take those small mesh, titanium mesh, and that you can fit there, and that acts as a sandwich between 2 layers of bone graft. That is how you deal with the protrusia. But if you have a doubt, always don't hesitate to go for a imaging intraoperatively. Only problem is patient is in lateral position, so maybe you will have to do that thing. In CDH also you have that issue, because your acetabulum is very shallow, and initially if you are not mentally prepared for putting a cup and this thing outside, it goes very outside, because there is no acetabulum. It's like a saucer only. So you go on rimming, make it medialized, still it is not possible, then use a small cup with a pseudo acetabulum. You have to make another acetabulum there. That you will learn gradually. That is the difficult cases. Initially, few cases don't do CDH or ankylosing. Go for a simple avian or basic cases. Once you have orientation, then always, and keep always backup. Tell somebody like senior person, "Yo, I am doing hip, be around. If I need any help, I'll give you a call or I'll give you a video call." So at least you have some backup there. That is very important. Because you know somebody is backing you up, then you are also mentally prepared. Okay, sir is sitting in the room, we'll do it. No, that is the easiest way to reduce anxiety also. Because you're doing alone without backup, then something happens, what do? At 11th hour, you cannot get somebody who's qualified and who's going to help you out here. Next.
So there is only one screw here. Is it,
See, basically what happens in uncemented cup, we usually don't put screw also if it is a snug fit. Problem happens, why? Because osteoporotic bone, one. Second, because company guys sometimes say, oh, 45 है 45 रिम करो या 45 है एक हेड बड़ा डालो. If you put that, sometimes you can have a fracture in the acetabulum or wall breakage. Suppose you follow proper rimming and proper sizing as per protocol, then you may not need a screw also, because that your trial is an original implant has that difference. It will definitely going to go and fit snugly. But still you are apprehensive, you are new, then you will say, okay, at least for safety we'll put one screw. So that we...
Not two, sir. What I wanted to ask is, if you're putting, you should be putting two or...
Not less, depends on the stability. Suppose it's a very rock solid, then just for preventing rotation, we are putting one screw.
But then one won't prevent rotation.
No, I know, but it's a snug fit. Most of the cases, we don't prefer to put screw. But suppose you have a doubt about stability, you doubt about bone quality, then you put a screw. Two screws are definitely preferable. Even if you have instability, you can put another third screw also, because this safe area is on the medial side also, on the posterior side. There you can put a screw in the ischial tuberosity. But that again you have to plan, and because various different designs of acetabulum are available. So when you choose implant or trial, that time you have to plan in your mind how many screws you're going to put. And accordingly you have to place that thing, because screws are going to go in the particular direction.
We gradually increase the size.
Yeah.
Some people do the small trimming in the center, then go for the upper size.
No, now because we have now the concept is changing, because we are now aiming for peripheral fit. So center ek bar, once you center or posterior or this medial side you are doing, because you want to remove the osteophytes from there. You want to medialize whatever possible. But your main fit is going to be in the center, in the periphery.
So जब हम पहला center वाला कर रहे हैं, medial वाला, do we get any feeling where we feel that okay, we should stop while doing the first?
No, bleeding will come. You have a condyloid fossa there, no? Cartilage comes out.
Sir, if there is bleeding but there is no press fit, both are possible. No? Sir, there is bleeding also, and also hold. Rimming का hold भी तो होना चाहिए सर.
No, rimming to gradually you go on increasing the size, no?
Sometimes there is bleeding but there is no fit. It's not bottoming out.
Okay.
You may have to.
No, basically we are rimming on periphery only. Proximal entry. Once your entry and this matches, this is 45, this is 45. Then it's, inside is not that important, because if you want to keep it away from the posterior wall or medial wall, that is also okay.
But initially there was this concept of circumferential fit. Now there is this concept of rim fit. Right, sir?
Yeah.
We believe in rim fit more than circumferential fit. So bottom out जैसा आप बोल रहे थे, bottom out का value उतना ज़्यादा अभी रहा नहीं है, जब तक especially anterior posterior pillar अगर उसमें अगर कप को बराबर से hold कर लिया है, bottom out ये इतना ज़्यादा नहीं, doesn't matter, because anyways cups are nowadays HA coated and porous coated cups रहते हैं, and there is this, if you have very good bleeding in the center of the thing, so what happens is there is bony overgrowth वहाँ से हो जाता है, and that thing gets covered up over the period of time. As far as your anterior and posterior pillars are fitting very nicely. Hold is very good.
Another important thing you have to keep in mind is hypotension, because we are not using any tourniquet here. So your anesthetist friend has to be really good. Take 10-xamic acid and this hypotension. Because if bleeding is happening, we have to talk to anesthetist and give hypotension. Because that will make your life easy. Unless you have injured some vessel or some tissue damage is more. Now we go for another case where it's basically a rheumatoid case where bilateral hip 8 years, TKR done 5 years, non-ambulatory since 1 year, and discuss about left hip. Yeah. Now this hip may be very difficult to dislocate also. Pehle in situ cut karke you remove a piece of bone and then remove piecemeal. Secondly, there is a protrusia here. That we have to see, and if required, you can, after removing, put lot of bone grafts and mesh as I told you. That is the simplest way. Sorry? That is okay. Let it be. But you have a good bone medially. So we are not going to expose this area. See, fortunately, what is there? The whole protrusia membrane, medial membrane, it's ossified. Whole thing has gone inside. So now we don't want to disturb this. Let this medial bone be as it is. How otherwise it's not going to help us. It's not going to bother us also. So we'll keep as it is. Your ilioischial line, we have to just maintain. You have to put a bone graft medial to the line. And if you feel bone graft is sufficient, what you removed from the acetabulum, or you can take some pieces of bone if there is a big cavity, and you can pack and then put a mesh there if required. Mesh will definitely help you in preventing it from going more medially.
We'll take a neck cut first?
Neck cut, 2 neck cuts, and remove the piece of bone like a biscuit. Remove that and then dislocate. Then you can gradually remove if it is coming out. Otherwise, like you use ankylosing mein karte, then directly you go and start removing.
So if this length is increasing, that will keep changing the length.
But sir, if the angle keeps changing, then the tension will change.
Huh?
If you change the stem angle, then that muscle tension will keep changing.
Stem angle तो change नहीं होगा ना. अभी uncemented stem में तो you put a well fitting stem ना. That is in cemented. Cemented में we used to put always valgus stem. So stem tip should always touch the medial cortex. अब वो concept खत्म हो गया ना. अब तो cemented, अब cemented करना है तो अभी भी वही है. So you should, उसमें कभी कभी ज़्यादा medial touch करता तो pain होता है thigh में या laterally touch. So this is valgus. This was not accepted. This is varus is accepted. Valgus is not accepted. So that means it is in varus. Lateral wall should not be touched. So this is what I was tell you. This, if you put it in the same and you increase the offset only, so that will not change the length, but that will change your hip center. So अगर vertical cup है तो there will be more wear and chances of dislocation. So there will be point loading. If you are horizontal, it will be more stable. And ये नहीं होगा medial thrust. तो protrusion में कभी-कभी हम लोग off ये डालते हैं horizontal cups protrusion में, because loading is more superior dome rather than medial. फिर neck length, so this you can increase. See this, even this length you can check. अगर तुम्हारा head में नहीं समझता, तो you can take from the tip of this to GT to see the horizontal offset.
यहाँ से इससे पास करो. That head का center, if you want valgus, line के ऊपर होना चाहिए head. If you want neutral, it should be at the line, and below के लिए below. For that you keep on changing the neck, but you need to remember the longer the neck you keep, उससे वर्जन चेंज ये चेंज होता है, ऑफसेट चेंज होता है. That is mainly because of how deep seating stem you are putting. If it is more deep seated, you want to increase the length so as to get that valgus angle. So that's when it happens.
So that will take a lower.
Sorry?
I didn't get that. You put the stem.
Suppose the stem has gone more deeper. You want that horizontal offset to be matching with that in the pre. Like in pre or proc, supposedly it's neutral. So you want this GT tip से जाने वाला जो रहेगा वो इधर है. अगर वो deep seated है, so what you tend to do is तुम stem का length बढ़ाते हो ताकि वो इधर पे आ जाए. लेकिन उससे ना ये
length बढ़ता है.
उसमें अगर नेक का स्टेम इंक्रीज करेंगे तो हॉरिजॉन्टल साइड से भी वो गैप इंक्रीज होता है. यू आर मेंटेनिंग द हॉरिजॉन्टल ऑफसेट बट यू आर इंक्रीजिंग द लैटरलाइज कर रहे हो तुम.
तो जीटी ग्लूटियस विल बी टाइट.
बाहर आएगा और जितना अंदर रहे उतना अच्छा माना सेफ माना जाए. हाँ मतलब ये जितना अंदर की तरफ जितना तुम बाहर स्ट्रेच कर रहे हो मस्कुलर स्ट्रेच मीडियलाइज
Standard offset and a high offset. Then where will you use
130. High offset is in high hip centers where your अभी जैसे प्रोट्रूज जो है उसमें भी हाई हिप सेंटर होता है. So you can slightly change your offset.
Standard is 135 degree and higher is 127 degree. If patient have a varus type of morphology, so his neck shaft angle is 127 degree. So high offset, which is neck cut, you don't usually change.
You don't change.
That is pretty much the same. You just you'll focus on if it is in varus configuration, you'll just use high offset.
Basically, this will be like higher offset will be like this, and standard offset stem will be like this.
135 degree, correct.
So if it is like this, that means the femur stem is coming more out. That means that tension should
No, it is not related. Both are not related.
ये है ना ये 135 होगा. तो लो ऑफसेट मीन्स ये ऐसा होगा.
वो नीचे की तरफ
नीचे होएगा. तो दैट इज इन CDH एंड ऑल दैट.
वो एंड नेक साइजिंग 0 1 2 जो बोल रहे हैं ना वो दोनों डिफरेंट कॉन्सेप्ट.
नेक साइजिंग इज नेक. इसमें ये बढ़ा भी देगा तो 135 ही रहेगा. ये इसी डायरेक्शन में जा रहा है. इट विल बी स्टिल इन द सेम डायरेक्शन. ये 135 ये अभी भी 135 ही है. हाँ दोनों चेंज हो गए.
ये जो स्टेम है अगर ये स्टेम इधर रहता प्लस आई वांट दिस काइंड ऑफ अ थिंग सो आई वुड हैव पुट अ लॉन्गर तब ये बाहर नेक का एक्स्ट्रा लेंथ whereas ये अभी इधर पे तो न्यूट्रल से अगर इधर आ रहा है दिस इज योर हॉरिजॉन्टल.
This is standard offset.
तो अभी इसमें आप अगर आप इसमें
दिस इज व्हाट आई वाज
higher offset डालते तो क्या होता?
इसमें हायर ऑफसेट डालते तो ये
ऑफसेट में हॉरिजॉन्टल भी चेंज होगा ना.
ऑफसेट बढ़ जाएगा.
हाई ऑफसेट में हॉरिजॉन्टल भी चेंज होगा.
Horizontal change.
in neck length vertical and horizontal both will change, but in offset only or horizontal because it will only go up. Why would it go down?
When you're talking about offset, you're talking about 96 degree. When you're talking about that, you're talking about length.
Yes.
वो नेक मतलब तेरा स्टेम नीचे चला गया तो तेरे को लेंथ लंबा चाहिए वाल्गस बनाने के लिए तो उसमें इंक्रीज हो. इसमें कुछ
इफ यू इंक्रीज द नेक लेंथ विद सेम ऑफसेट तो उसमें कुछ चेंज नहीं होगा. उसमें हॉरिजॉन्टल भी सेम ही रहेगा. वर्टिकल चेंज होगा बट हॉरिजॉन्टल चेंज नहीं होगा. वो तो सेम एंगल पे है ना. ये देखना ये ऐसा ऐसा. सो दिस इज दिस पोजीशन एंड दिस इट इज स्टिल द सेम बट ये चेंज होगा. ये ऊपर जाता है. ये तो हो गया ऑपरेटिव स्टेप्स. पोस्ट ऑपरेटिव एनालिसिस सेम है. दूसरा ये तो वो दिखाया ना उसने पहले ही. ये दूसरा केस भी है.
हाँ 5 केसेस.
ठीक क्या है क्या है.
नहीं बहुत सारे.
चलो 36-year-old rheumatoid chronic pain 8 years delayed ligament 5 years no ओके. चलो इसमें बोलो क्या है. बायलैटरल प्रोट्रूजियो. तो इसमें क्या करोगी. फर्स्ट तो वही लिम लेंथ, यू हैव टू डॉक्यूमेंट बोथ साइड्स लिम लेंथ क्या है. So lesser trochanter seems ये side is shorter, left side seems to be shorter. So now what do you do? How do you plan? एक साइड ले लो पहले, राइट चलो. So there is protrusio head is completely gone. Collar line क्या होता है? Collar line ये extend this line. So this is gone beyond that. So there will be medial wall breach, widening of the acetabulum, wall integrity we'll have to see. Posterior wall कुछ दिखता तो है नहीं, ये कुछ तो है इधर. So अगर lateral होगा नहीं होगा, तो इसमें क्या क्या करोगे अभी? X-ray finding is protrusio both sides, head is completely gone, and so और कुछ X-ray, CT obviously you need to do CT, see the cup integrity, wall कितना है, breach कितना है. Management, इसमें प्रॉब्लम्स क्या क्या होंगी? एक तो वही वाइडन एस्टेबुलम है, साइज, पोस्टीरियर वॉल देखना, इंटेग्रिटी ऑफ द पोस्टीरियर वॉल विच इज़ वेरी इंपॉर्टेंट. आजकल अच्छे कप्स भी हैं हु नीड ओनली 70 to 80% ऑफ द कप होल्ड, बट स्टिल यू नीड टू हैव सम पोस्टीरियर होल्ड. So you have to plan accordingly. Then you might need bone graft, but the head is gone, so there is no bone graft also. You will have to take allograft. So problems will be, one, cup hold, so size of the cup, two, how much medialization, lateralization you need to do. So in this case you need to lateralize, in fact, you don't medialize. So you need to pack the whole thing with graft. And कैसे करते हैं प्रोट्रूजो की ग्राफ्टिंग? So abductors will be weak, so they will be thinned out, so you have to, while exposing, you have to be sure you don't cut them. So dislocation will be difficult. You might have to do neck cut first, osteotomy. Even then you may not be able to do it. So many times you do even acetabular osteotomy, rim osteotomy. Just cut the posterior wall a little bit so that you expose more. Can't say, कुछ तो दिखता है पीछे, but I am saying होना तो नहीं चाहिए. Posterior में posterior wall नहीं जाता है generally, but you should get a CT to know that. So protrusio head resorption is there, arthritic hip, high riding GT. So dislocation will be tough, so you have to be ready for that. So take a neck cut first, pull it out slowly, or add a periarticular osteotomy of the acetabular, and then rest of the head. Sometimes you may not get the margin of the articular surface of the head and the acetabular, so the distinction between is tough. So in those cases you do reaming of the directly head on the top. So try to keep reaming, then you will start getting the distinction. So the whole this thing. So if you try to dig it out the head, it might breach, you might break the posterior wall, you might cause impaction of the posterior wall. So if you are able to get it out, good. If you are not able to get it, then slowly try to ream it, the head itself. So अंदर ही ream करके, कट के बाद अंदर ream कर. हाँ, so it is एक तो lateralized है. आप तो इधर लगता है, but I am not very sure. Not necessary. Reaming. Post wall reaming करना ही नहीं है. You have to pack it only the rim. So you, once you have the whole head is out, you just remove any cartilage which may not be there anyway, but just try to remove any cartilage with the curette itself. Then just do feel the posterior wall, medial wall. It may be soft. So then you start packing the graft there. So pack it. That is why he has done. This is all graft, I think. Graft डाला है.
No, the cup is like inferior.
शैलो नहीं है, इसको टच तो कर रहा है इधर. ये देखो ना इसका. If you trace this line, so it is just about. I think it is okay. Only thing is it is vertical. So that is why अगर वो horizontal over करता है यहाँ लाता है इसको, this would have also gone in.
This was that tal.
So this is a vertical cup. It works, but only thing is that it should not loosen out, or it will cause edge loading. So many times slowly the liner gets. हाँ ये सीमेंटेड डाला है ना उसने, वो ज़्यादा सिंक हुआ है. ठीक है, यहाँ तो ठीक लग रहा है. यहाँ जीटी का है, आई थिंक ब्रोकन है जीटी. He must have broken the GT.
So we should have taken more lateralized actually. Then it would have
No, I think this is broken. ये GT है.
नीचे से टिप तो उसने वाल्वस स्टेप्स कर दिए.
हाँ?
Inferior border of the cup is outside the tank.
Bigger से ज़्यादा I think it is vertical ना. ये कहाँ है? अगर ये horizontal है, see this line, draw this line, and this line. तो इसका 45 degrees. So this is almost 70 degrees. 45 degrees. So अगर ये 45 लाएगा, ये टिप यहाँ आएगा शायद. So this उतना ही बार. हाँ, this is cemented stem ना. हाँ, so in cemented stem, this should touch here. This should be more medial, closer to the medial wall. Charnley was ये neck shaft angle की बात कर रहा है. Can't वारस stem क्यों यूज करेगा? ये उस C stem जैसा है, वो C stem बोलते हैं ना, वैसा लग रहा है. Neck shaft angle ठीक ही है 130. I don't know what's
last 10 minutes.
So operative steps, as I told you now, only thing is grafting कैसे करते हैं protruso की. So first you just do shallow reaming, just to roughen it up a little bit. Don't push. So roughen it, then start putting graft. So उसमें I do it little, I don't know, I can't say differently, but I put first पहले एक वो एलोग्राफ्ट का या अगर हेड होगा तो हेड का जस्ट पुट द टॉप कैप, उसको रिवर्स में डालते हैं सो दैट पैकेट. समटाइम्स यू पुट अ मैश सो दैट ग्राफ्ट डजंट गो इनसाइड. सो यू पुट अ मैश, फोल्ड इट इनसाइड एंड देन इट कैन गो इनटू द पेल्विस पार्शियली. कीप इट अ लिटिल आउट, फ्लोइंग एजेस लाइक फ्लावर, सो दैट उस पे बोन आ जाए, सो दैट इट डजंट गो इन. इट डजंट. सो मैश, और यू कैन पुट अ बोन का ही कैप जैसा डाल के जस्ट स्लाइस ऑफ द हेड. फीमर किधर गया? फीमर. सो जस्ट स्लाइस ऑफ दिस हेड, छोटा सा इधर इतना सा, पुट इट एज अ टोपी देयर टू रेस्ट्रिक्टर जैसा. देन पुट थिकर ग्राफ्ट, मीन ग्रेवल ग्राफ्ट बोलते हैं उसको. दैट इज थिकर पीसेस. निबलर से जो काटते हैं ना, थोड़े बड़े बड़े पीसेस. जैसे रोड कैसे बनाते हैं, रोड में पहले ग्रेवल डालते हैं, पत्थर बड़े छोटे छोटे, फिर सैंड डालते हैं उसमें पैक करने के, फिर टार डालते हैं. So patthar is thicker graft. Then you can put this shavings which are mushy, which are little softer. So then pack it and then do good impaction. So keep on impacting it. कट वो शुरू में लगता है बहुत ओवरवेलमिंग, बहुत ग्राफ्ट हो गया, बट इफ यू कीप ऑन प्रेसिंग इट तभी वो बॉल बनता है पीछे. ये जो उसने बनाया पीछे, ये ग्राफ्ट की वजह से भी ऐसा भरना चाहिए पूरा ये. द होल थिंग बिकम्स वेरी थिक. यहाँ तक ये ग्राफ्ट ही है होपफुली.
मार्जिन दिख रहा है उसके.
हाँ. So this is all. Actual posterior wall is the medial wall is this. ये original होगा. So this is all graft filled so that it consolidates later. थोड़ा नीचे डालें. हाँ. Which wall? नहीं ब्रोकन क्यों, पेल्विस में जाएगा. इसके लिए तो यू नीड उधर मैश भी डालते हैं.
वो टूट जाता है जिसने भी किया है. फॉर हिम द मेम्ब्रेन वाज वेरी गुड.
वो फाइब्रोटिक होता है ना थोड़ा. इट इज नॉट वेरी, मतलब अंदर घुस जाएगा ब्लैडर में.
सपोर्ट रहता है.
इट इज सो डोंट ब्रीच दैट, डोंट ब्रेक दैट. उल्टा उसको और रेनफोर्स करो. दैट इज व्हाई आई पुट दैट टोपी हेड की छोटी सी. और अगर तुमको नहीं है तो मैश डाल सकते हो. मैश का लेकिन जो एजेस आते हैं वो बाहर लाओ, कप में लाओ, सो दैट इट हैज अ स्कैफोल्डिंग देयर. उसके ऊपर ग्राफ्टिंग करते रहो सो दैट गेट्स अ गुड होल्ड. यस, इट एक्ट्स एज अ नेट. मेटल का भी डाल सकते हैं. मेटल लेकिन मिलता नहीं है बहुत कॉमनली. तो प्रोलिन मैश इज इन ऑलमोस्ट एवरी ओटी इट इज अवेलेबल. प्रोलिन मैश वो डाल के देन वो थिकर ग्राफ्ट, देन दिस पट्टी जो होता है, जो सॉफ्ट हलवा, वो डाल के देन इट बिकम्स वेरी स्मूथ. बट कीप ऑन कंप्रेसिंग इट. वो फीमर हेड का जो इम्पैक्टर आता है ना, उसी से कट ऐसा करते जाओ. इट टेक्स 10-15 मिनट्स. सो देन यू हैव अ वेरी स्मूथ पोस्टीरियर वॉल एंड देन पुट द ट्रायल. यू कैन डू रिवर्स रीमिंग, उससे भी वो बैठ जाता है.
पूरा वॉल अगर फोड़ा है तो
केज तो यू कैन डू इट, बट आई ऑलवेज फील केज इज वेरी मॉर्बिड प्रोसीजर, प्लस इट डजंट लास्ट लॉन्ग. Cage should be last. In fact, jumbo cups are now good. So you can put a very large cup. They have good hold on the rim, and now the metal tribology they have improved so much that वो तुम 1-1.5 महीने में कप इंटीग्रेट हो जाता है. So gription cup या tantalum cups, they are all good penetration of bone into them. So they get stability very fast. हमने एक कप 15-20 दिन में खोला था, वो निकला ही नहीं. So gription cup, they are very highly porotic metal, so their integration is very good. That is why you should use a special cup in such where you want a rim fit. But it is very important that you get a good rim. So that is why finally you don't get scared in that. Unless your wall is thinning out very severely, otherwise keep on putting a bigger cup so that you should get a good hold of the cup. And floor is absolutely just to fill it up. It doesn't give any integrity to the cup. So operative steps हो गया. चलो third. Pain in left thigh, inability to weight bear both gradually and since 8 months. Done. Okay. चलो this is a different. इसमें अभी क्या क्या है बोलो. Cup. This is all loosened out. Cement is there. This is called dilatatory remodeling. मतलब dilate जैसा होता है bone. So this is very thin cortex. It will break very easily. पेपर थिन होता है वो. इम्प्लांट में भी प्लेट भी डाला हो, कभी कभी लूज होता है तो वो भी ऐसा ही. इट्स कॉल्ड एज डायलिटेटरी रिमॉडलिंग. तो ये सीमेंट है, कहीं कहीं पैची सीमेंट है. सो स्टेम इज लूज, इट शुड कम आउट क्वाइट इजीली. ओनली थिंग इज दीज सीमेंट पीसेज यू हैव टू टेक आउट. सो यू कैन नॉट ब्रीच दैट. सो दैट इज वेरी टफ. सो मैनी टाइम्स यू माइट हैव टू डू एन ऑस्टियोटमी to remove it. Many times I have done this, just this osteotomy आधा, तो इधर से ये निकाल के ये निकाल. ETO बहुत एक्सटेंसिव हो जाता है. Only thing is उसका थोड़ा avian होता है, but if you only the tip का osteotomy नहीं, इधर का इधर तक, इधर से इधर तक. और दूसरा इधर भी वाइडनिंग हो गई है. सो यू कैन सी हियर Proper protrusive तो नहीं है, floor seems to be intact still, so it should not be a very tough job, unless it is infection.
Not to hammer the cup a lot in this.
तो क्या करोगे infection rule out करने के लिए? तो biochemical parameters and biochemical में CBC, ASR, CRP. दूसरा aspiration. Aspiration में क्या मिलता है? Cell count कितना होना चाहिए? WBC count, neutrophil count. What is significant? नहीं रे, 1000 कितना होता है? 1000 cells per field अगर आ गया तो it is highly chances of infection. That is even prognostic. बाद में तुमने वापस एस्पिरेशन किया एंटीबायोटिक. If they are still above 1000, that means I think 1000 है कि 3000 है? 1000 है ना, कितना? 1000 है शायद. So that is 2 and culture obviously. So then you will do it 2 stage. ल्यूकोसाइट बाइंडिंग स्कैन्स करते थे बट अभी जरूरत नहीं है. अभी तो इफ एट ऑल यू वांट टू डू यू कैन डू पेट स्कैन, बट जरूरत नहीं है. अनलेस यू गेट अ कल्चर नथिंग एल्स विल टेल यू द राइट स्टोरी. सो यू हैव टू गेट अ नेगेटिव कल्चर अगर करना है तो. And safer is always in such situation to do it in 2 stages. Dire means if you want to do it immediately, then you have to send it in the OT, and then do a frozen us time. 6 weeks.
Last 5 minutes.
6 weeks or negative culture after 6 weeks. अगर नहीं आया तो वापस repeat. Yes, always. Even if you are happy, satisfied that there is no local pus, you send the culture as a and take cultures at different points like tip का stem पे, acetobulum में, at least 6 to 8 sites. So anyone you might get culture positive. So endosteal ballooning, periosteal sign. Periosteal sign क्या होता है? Periosteal sign is like a step here. वो sclerotic bone आएगा. So that means there is loosening. This might be pedestal. ये has a step बना है उधर. That becomes वो reactive sclerosis. So loose stem can cause that. Paprosky classification है वो कोई thin out हो गया significant fracture balloon oil implant removed. वही मैंने बोला ना तोड़ेगा. I have not seen this. हाँ उसने वो किया होगा आधा ऑस्ट्रेट. मैंने नहीं किया है, किसी और ने किया है. मगर आई ऑल्सो डू दिस, बट ओनली थिंग इज दैट यू हैव टू बी वेरी कॉशियस. यू शुड पुट अ प्रायर प्लेट और यू शुड होल्ड इट विद इनिशियली यू शुड पुट वायर्स. Yeah, I put stimulant.
When that PEL kind of a thing for this, I have never done this kind of short use किया.
ये पहले करते थे, अभी तो रेगुलर स्टेम्स आता है. और इसने तोड़ा होगा ना, इसलिए उसने ये डाला है. He must have broken it, na? That is why. He must have broken it while osteotomy.
Provisional stability के लिए.
Then you have no choice. You have to put a nail. You cannot do anything. और वो जो उसमें फिर एडिशनल वो अगर इफ यू गेट अ रेडीमेड स्पेसर ऑल्सो देन यू कैन पुट एन एडिशनल नेल ऑन टॉप.
वो जैसा वो YK वायर उसके ऊपर ये ऐसा कटिंग किया
पर ये तो बहुत ही लंबा था.
instead of elders never
Now this is the revision. कितना distally you should go to the fracture site? We're using a revision stem. No, अगर suppose नीचे fracture हुआ था stem डाल के तो then you have to put plate on it. No, the stem is inside. It doesn't matter. नीचे तेरा adequate 6 centimeters तक आ गया तो बहुत है. इसमें actually कुछ भी जरूरत नहीं है. But only thing is he must have put wires because to hold. This must have all ballooned out while putting the stem.
Fragments पकड़ के रखने के लिए.
Many times तो खाली हो वो पूरा thinned out हुआ तो allograft डालते हैं इधर. यहाँ पूरा एक या fibula डालते हैं. साइड में ये कॉर्टेक्स थिन्ड आउट है ना. ये अभी दिस इज अ डिस्टल लोडिंग स्टेम ना. दिस इज हेयर. सो दिस माइट इवन इफ यू सी आफ्टर 2 years दिस माइट ऑल एब्जॉर्ब्ड और हवा में रहेगा बिकॉज देयर इज नो स्ट्रेस लोडिंग ना. सो दिस माइट इवन वैनिश एटलीस्ट दिस पार्ट.
That's why it has got थोड़ा इस तरह because the stem is deeply seated. उसको 6 mm और चाहिए तो उसने और deeply seat किया तो ये भर गया तो
फिबुला डालो इधर डालते हैं. यू कैन पुट 2, 1 on this side, half of fibula, 1 on this side, 1 on that. हम लोग पहले करते थे जब हमको इतना रिवीजन स्टेम्स अवेलेबल नहीं होती थी ना तो नॉर्मल स्टेम के साथ या तो प्लेट या तो फिबुला डाल के ऊपर से प्लेट बहुत कुछ डालते थे. Half of them used to fail and infect or this or that, but तभी we didn't have any choice. Now these stems are excellent. That is why it will hold for 10 years. But this can get lost. The osteolysis होता है because there is no stress loading on this. Na? The whole load is on this, so it is from directly either to either. Yeah. Even GT many times हम osteotomy करते हैं GT, so that GT never unites. उस पे loading ही नहीं होती. It is like अपना इसका GT. ये नहीं है राम टिका मेरा ही गाना है क्या है मेरा ही दिखा ना तुझे
बोलेगा नहीं तो किधर कॉम्प्लिकेशन में जाओ बस.
मेरा ही कॉम्प्लिकेशन दिखाना. सो दिस इज क्रॉनिक अल्कोहलिक बायलैटरल एवियन. उसको कुछ तो डिफॉर्मिटी था फिर FFD वगैरह. सो लेफ्ट पहले किया था. So usual, nothing unusual. You can see the large osteophyte. So tile के आजू बाजू osteophyte बड़ा रहेगा. So seeing tile will be difficult here. This is your osteophyte again. So this even on while reaming you should remember this. So this you can be little, you can go on the inside. Your cup may not be flush with air. You can have that. You can give up. So seeing pre-op X-ray is very important. That is why you should see this. So तुमको मालूम है तुमको थोड़ा error margin है. So you don't have to be exactly flush with the rim. You can go little inside. So this cup would be 45 degrees. So your tile will be somewhere. ये तेरा ये है. ये ऐसा आएगा. So your this is 45 degrees. So you don't have to actually measure things. You can make out telltale signs जो रहते हैं ना वो. So your medial wall कितना ream करना है. So there is no protrusion. You can do good amount of reaming inside. So diagnosis पता है. Management is THR. Operative planning कुछ खास नहीं है. Usual है. Patient position भी same है. So this is this. So this is what I was telling you. You can go inside. So it is now flush with the lateral margin. Only thing is we could have still gone little medium.
So this thing, intraoperatively, like now, when we see the post-op X-ray, we are like और अंदर जा सकते हैं.
कोई नॉर्मल तो सिखाने थे. तो बिल्कुल मेरा दिखा के ही रहेगा, छोड़ेगा। मैं डिले कर रहा हूँ तो
राइट साइड
उधर ही जा रहा है।
सेकंड एकदम
हाँ।
दिस इज इमीडिएट पोस्ट ऑफ।
इसमें क्या कुछ पता चल रहा है तुमको? कुछ स्टेम मस्त था उसका, कप में प्रॉब्लम है।
रेट्रो वर्जन, रेट्रो
लास्ट 2-3 मिनट्स।
कप एंटी वर्जन रहेगा ना,
कप रेट्रो नहीं, मोर एंटी वर्जन।
कप एंटी रहेगा तब ना रेट्रो गया ना।
सो नहीं, ये अभी स्टेम डिसलोकेटेड है ना, इसके लिए ऐसा लग रहा है। ऐसा ही है, सेम ही है। ये बेसिकली कप इज इन, कप इज, ये अगर तुमको ये होल ऐसे दिख रहा है ना, दैट मीन देयर इज समथिंग रॉन्ग। ये जो होल दिख रहा है ना,
ऑन टेबल दिखेगा तो तू कर सकता है। ऑन टेबल
3 होल वाले कप में तुझे होल ऐसा नहीं दिखना चाहिए। और मार्जिन्स इफ यू कैन, अभी यहाँ तो थोड़ा ओवरलैप है। सो दिस, सी दिस ना, इफ योर एपी इज परफेक्ट, मार्जिन में इतना ओब्लांग कप नहीं दिखना चाहिए। यू शुड सी द हेमिस्फीयर। हाँ, दिस इज बेटर देन दिस एक्चुअली, लेकिन इसका अलग लग गया। सो दिस इज, दैट इज व्हाट आई वाज सेइंग, इफ योर एंटीरियर मार्जिन से तुम्हारा कप, सो इफ योर एंटीरियर मार्जिन इज टू प्राउड, ऐसे दिख रहा है ऐसा, तो तुमने एंटीवर्शन ज्यादा दिया है। कम दिया है कि ज्यादा दिया है? ये कम हो गया,
एंटी वर्जन ज्यादा है ना।
कम हो गया, ज्यादा हो गया?
ज्यादा हो गया, ज्यादा हो गया।
हाँ, ये कप का वर्जन ज्यादा हो गया। सो यही उसमें हुआ था। सो दिस हैज बीन दिस। सो उसके बाद भी हमने वो ऑस्टियोफाइड निकाल दिया। सो इफ यू शुड सी प्रीऑपरेटिवली और ड्यूरिंग सर्जरी दैट तुम्हारा वर्जन लाइन बराबर है कि नहीं, ऑस्टियोफाइड। सो डोंट ट्राई टू, इफ यू आर गोइंग इनसाइड दिस ट्रायल में, दैट मीन्स योर वर्जन इज आइदर ज्यादा या तो कुछ गड़बड़ है। So that is why I was always saying that you should be flush with this at the end of it. Anterior margin को flush रखो। Posterior किधर आता है, नंगा होता है या overlap आता है, doesn't matter.
You have posterior leg, that is one support at least you have with posterior.
So वो जब वो supine ये रखते थे ना, वो ठीक रखते थे। उसका एक्सरे हमको ठीक लगा अंदर। The moment उसने एक्सरे के लिया, ये एक्सटर्नल रोटेशन में जाता था, इट यूज्ड टू बी इंटरनल रोटेशन रखा तो अंदर जाता था।
मोर एंटी वर्जन रखा, उसकी वजह से एंटीरियर डिस्लोकेशन।
हाँ, वो ऐसा होता था, एंटीरियर डिस्लोकेशन। सो दिस वाज दिस। वो अभी इंटरनल रोटेट किया तो अंदर आता था, एक्सटर्नल रोटेट किया तो बाहर आता। जो एक्सरे के लिए उसने एक बार लिया कुछ तो अंदर ही था, उसने बोला छोड़ देते हैं, बाहर आता।
सपोर्ट ही नहीं था एंटीरियर।
उसमें पेपर्स आ गए, तुम लोग खाली उसको इंटरनल रोटेशन में रखो, 6 वीक्स में स्टेबल हो जाता है। बट हमने किया है, नहीं रहा स्टेबल। वी हैव टू रिवाइज। यस, वही है। यू कैन सी दिस, दिस इज गुड। ये देखो, ये पोस्टीरियर इज मैचिंग हियर, ये अंदर गया है, विच शुड बी एक्चुअली रिवर्स। Anterior should be matching. ये यहाँ भी है, ये देखो। So it is, तो फिर हमने रिवाइज किया। एक कप कुछ तो आई थिंक 20 दिन में ही हमने रिवाइज किया, तो इट वाज ऑलमोस्ट इंटीग्रेटेड था।
So time's up now. Let's everyone gather here for group picture.
This is solution step. नहीं, solution है कि इंडियन। इसमें क्या करोगे, कप कैसे, हेड कैसे करोगे? तो दिस विल नीड एन ऑस्टियोटमी फर्स्ट, फिर उसको स्टेबुलम का ऑस्टियोटमी